So I would request Dr. Harshal to kindly introduce the panelists for this panel, that is Orthopedic Crossroads. It's a case-based discussion.
Yeah, good morning all. It is always nice to come back to your alma mater. A little bit overwhelmed today with the morning talk of Dr. Ramchandra sir. And now we are going to discuss about the case-based approaches, particularly the orthopedic cases. And for that, I would like to invite Dr. Mayank Vijay Varghia. He's a consultant orthopedic and joint replacement and trauma reconstruction surgeon, and primarily expertise in the robotic assisted joint replacement. Welcome, sir. Then I would like to invite our very own Dr. Vikas Agashe sir. I think sir requires no introduction. Everybody working in the field of orthopedics and the endocrinology knows sir. He's quite a senior orthopedician with lots of experience in the managing lots of complicated orthopedic cases. Then our yes, then Dr. Neeraj Bijlani sir. Sir is so orthopedician at Orthotech Clinic and Sai Baba Hospital, specialized in minimally invasive orthopedic surgery with specialization in trauma surgery, spine and joint replacement. So I'd like to invite Dr. Ramchandra sir also. I think now you are well aware about Dr. Ramchandra sir, very renowned spine surgeon. Yeah. Thank you.
Morning, friends. So we'll start with the orthopedic cases. This was almost 20 years ago. I was called in to ICU. Sir, urgently aa jao. There was a 15-year-old boy who had extremely severe pain in hip and right lower limb after he had convulsions during his first dialysis. So to go through the history, he had fatigability for 2 years, had mild pain in left hip for several months, had sustained tibia fibula fracture about 2 years ago. And interestingly, the parents said that the plaster was kept for almost 8 months. And just about 2 weeks prior to he came to Hinduja, he was diagnosed to have chronic renal failure. And that is when he was treated with dialysis. And here you can see there's a very severe osteomalacia. There's an acute fracture on the right side. There's a malunited fracture of the left neck femur. So we have very severe osteomalacia, acute neck femur on the right side, and femur fracture on the left side. His calcium was 4.9, phosphorus was 7.9, his alkaline phosphatase was sky high, and creatinine was 17. So basically, the child was in extreme pain. The relatives were really upset that this has happened after dialysis. And what next? How should I treat his neck fever? Can I open it for discussion? Yeah.
Has he been given fitness for surgery first by the physicians?
Yeah. So, absolutely. First thing, First thing.
Because with these investigations, it looks like a very unfit patient.
Yes,
Huh.
absolutely.
Hmm.
Absolutely.
So first
Sure.
calcium needs to be corrected. Calcium, and I think vitamin D was, I don't know whether it was tested or not.
Yeah, it was tested.
Yeah.
It was normal.
Okay.
So essentially, the nephrologist said that he's a pakka candidate for bypass. There is no way we can treat him. Till then, of course, he needs dialysis, but he has to be treated with bypass.
Transplant, that is what you mean.
Transplant. Sorry, not bypass.
Transplant.
Transplant. I am sorry. Transplant. Dialysis followed by transplant. Now the question is, what do I do? Do I fix immediately? Do I fix after biochemical markers? To some extent improve with dialysis? Or I try and fix after transplant? Or I do immediate processes? Dr. Chadda, your opinion?
So first and foremost, I'll thank the Almighty that the patient is admitted with the nephrologist. क्योंकि ये पेशेंट अगर आपके या मेरे नीचे एडमिट होगा तो बहुत तकलीफ होगी सर.
Obviously.
So let them remain the captains of the ship, and we should just come there and help the patient within whatever we know. So we can fix this fracture, we can replace this fracture. I would rather fix it because he is a young child, 13-year-old, and I would not now like to just know what is the quality of bone when I'm going to indulge in fixation. That's my thought process.
Correct.
If there is a way by which many years back you had ways to find out what you would anticipate when you went in with a fixation modality, you would do that. And again, you would have your esteemed nephrologist and esteemed endocrinologist giving you the answers. We do not have answers to these things. So that's where I work. Yes, I would like to fix him with the best modality once I'm sure about the quality of bone.
So, generally, I mean, most of the references suggested that in chronic renal failure, fixation produces very poor results. And the treatment modality, even at young age, was suggested to be hip replacement. However, I felt that it's pointless doing any kind of fixation at that stage. As you said, let the nephrologist be captain. And with dialysis, he started improving. His serum calcium improved. His creatinine started coming down. And then he was very uncomfortable. Now, at this stage, the nephrologists were after me. Ki kuch karo. Now he is very, very uncomfortable. And his calcium has improved. His creatinine has come down. Now do something. This is about 3 weeks after starting dialysis. Now what should I do? He's uncomfortable. What should I do? The literature suggests that fixation will certainly give way. A replacement, of course, that also will give.
I will still plan fixation. And I may try to incorporate something unconventional because I may not be able to put a conventional, minimally invasive, strong implant in. I may even try to do something like a retrograde enders with a combination of something like a figure of 8 on the trochanter is my thought process right now, because that's one thing where I'm not breaking cortical bone in the area of the injury. My cortical disruption is elsewhere. And in the area of the injury, I am actually respecting the biology. That's my thought process.
Some Indian jugaad you will have to have.
Sir, I want to ask the endocrinologist here that in 2 months of treatment, the calcium has gone up, vitamin D has gone up, whatever these things have gone up. How much time will the bone density improve in 1 or 2 months? Not at all. There will be no difference whether we would have operated 2 months back or now. Healing will be better, but bone density may not have improved. It takes how much time for it to improve? At least 1 year.
Yes. Yeah, with the renal osteodystrophy, if I may step in, to improve the bone quality is actually a very difficult task. What we can do is that we can improve the metabolic factors, we can improve the calcium and the phosphorus, we can classify disease whether it is a high turnover renal osteodystrophy or a low turnover renal osteodystrophy, based on which we can actually plan the anti-resorptive or the anabolic therapy. But patients with presenting with the fracture and these high metabolic parameters, first we need to classify that disease, then go ahead with the fixation, and thereafter, for a better outcome of the fixation, we can take the help of the medical therapy to improve the bone quality.
So overall, it's very challenging. And only thing is, in this patient, the nephrologists were very, very clear that he has to undergo bypass. And I was honestly not very sure of achieving any kind of stability with any implant. I thought whatever I do would fail. So I said, let me wait till he undergoes a transplant. And that was supposed to be in near future. So I just waited. I mean, every day there would be discussion, kuch karo, isko bahut dukta hai. So I said, nahi karunga. Because I'm not sure, not because of anything, I said, I'm not sure whether I'll be able to achieve anything. Yes. Sorry.
Process was not a contraindication to healing.
Absolutely.
Please, we have to understand that very clearly. It may still heal. A lot of fractures heal despite us.
Absolutely. The problem is significant virus. We had to correct his virus, and we need to have some stability for some anchorage for the implant, which I felt that we will not get. Yes.
The question is why he undergoes a transplant. What changes? So you said you would like to wait for the transplant to occur before you decide.
Right.
How long? I mean, the bone quality is not going to improve immediately after a transplant. It might take months to years. So how would the date of the transplant change your decision whether you want to, whatever you think?
Correct. So let me...
is correct.
Absolutely. Let me take you through the case. So 25th May, about 45 days after his first convulsion, he underwent transplant. His biochemical markers started improving significantly. By 1st May, the biochemical markers improved. And you will not believe, 31st August, 13 weeks post-op, he came walking to my room. And you can see the bone quality. Fantastic bone. Fantastic. He just came walking. He's been walking for 1 month before he came to me. So about 9 weeks, 10 weeks after transplant, he started walking. And you can see that's on day of transplant, that's 13 weeks. So moment kidneys take over, the bone quality improves significantly. Then things were very easy for me. I was, the wicket was good. All I had to do was do a corrective osteotomy. That's all. So that's the planning for corrective osteotomy. It was a little difficult because there was significant retroversion. But all in all, this is 7 weeks post fracture. I did osteotomy on the right side. Three months after that, left side. This is 1 year. You can see excellent consolidation and function. This is 10 years. Very, very comfortable. So moment his kidney took over, the bone quality improved fantastically. Otherwise, with dialysis, the quality doesn't improve. The bone quality always remains poor. So So this is day one when I saw him. It's not going further. Yeah. So 45 days, 14 weeks, 22 weeks, 52 weeks, and 10 years. Absolutely leading normal life. There have been several papers, rather case studies of spontaneous fractionic femur or fractionic femur following convulsions in chronic renal failure. And all in all, it has been a very, very challenging situation. Like this patient, three cases described. First case died of medical reasons. Second, they just said that we did a osteotomy and fibular graft, but did not mention anything about the result. Case 3 got infected, debrided, but died of medical cause. So all in all, fixation also in chronic renal failure, especially in younger age, has not produced very good results. Another basically letter to editor, they said hemiarthroplasty done, but the follow-up was not described. So all in all, this is a very, very challenging situation. And in case you think that patient is likely to undergo transplant, then it is best to wait. Then you are on a much better wicket, because the moment you have functioning kidney, the bone metabolism improves. So cases with florid metabolic disease, worthwhile waiting till the activity of disease decreases. Doing a well-planned corrective osteotomy was extremely easy for me, rather than doing any kind of fixation, and I was sure that I would not get a very good hold. So I think this basically highlights role of kidney in bone disease. Yes, please.
Sir, he was lucky to find you, and as well as lucky to find the kidneys. Now, what if the transplant time was very long?
Yes.
So then what, how the management would have changed from your side?
Then, of course, I would have been forced to do some kind of fixation, which would need fixation as well as an osteotomy, because patient had there was a significant virus at the neck. And unless you correct the virus, the fracture neck femur would not heal. So there would be a fracture, plus there would be an osteotomy. So fracture healing would be needed at two places, which would again be challenging. When you operate then? Moment the biochemical markers improve.
So maybe at that point when the patient was again deteriorated, when the patient again deteriorated and they were begging for the surgery.
Hello, can we go to the next?
So when the patient deteriorated and when they were begging for the surgery, you would have decided to fix him if he was not on the transplant list?
Possibly after about 2 months. Possibly after about.
Sir, in those days, 20 years back, it was easier, as he said, to get a transplant. So anyways, you waited for 4-5 months. You waited for 3 to 4 months before you went for surgery. After the transplant, you waited for 3 months. Plus before also patient waited for 2 months. So total 5 months. So what would have happened that, as they say, that the bone density would have improved after 6 months. So 5 to 6 months waiting would have been better. It would have at least improved the bone metabolism better instead of waiting only for 2 months.
For doing an osteotomy?
Yes.
By then the bone quality was excellent.
Not here, in such a situation, not where the transplant was happening.
Achha.
In a similar situation where transplant is not happening, only dialysis, as the endocrinologist said that after 4 to 5 months, the bone density will anyways improve, even with dialysis, or it will not improve.
Yeah, I'm Thomas. Basically, when we look at it, so this is mostly driven by parathyroid disease, severe parathyroid disease. You see calcium has dropped and all these things. The moment you act, starting in addition to dialysis, giving all the cocktail, then you are reducing the osteomalacia component. The best parameter for that is a bone-specific alkaline. Of course, we have seen the alkaline, which Sir was saying. The moment it starts coming down, which we have shown in published, we have a 4-year follow-up study, which we have published from CMC Vello, 50 patients. So the moment you start suppressing, the BMD start increasing. So there is some time, as early as 6 months, the moment to correct it, the BMD can mount up to 16, 20%. Though quality cannot be assured. The quantity may improve, but we don't know what will be the quality. So it all varies, but the PTH plays a role. The parameter will be, which I will be happy is PTH coming down, not too much suppression, and alkaline phosphatase coming to around 120, 200.
Take home that if there is no that's what I'm understanding. The patient is not having any relative to the renal transplant. And nowadays, renal transplant has become very difficult. Right? Later are allowed? Not sure that. Yeah, are relatives allowed to do renal transplant? Acha, they are allowed now. First degree allowed. First degree. Spouses and parents can give. Yeah. Yes. Yeah. So if the patient does not have anybody to give the kidney, then the ideal waiting period also remains the same, that he says that 4 to 6 months should be the proper time to wait, and instead of doing in 1 or 2 months. So basically, this one more thing which I think orthopedic surgeons should take home from this is that surgery करने का जल्दी नहीं होना चाहिए. Just because you are getting outside pressure from endocrinologist and physician, the decision should always be yours when to operate.
It's a combined decision. I wouldn't say it has to be a combined decision. Yeah. So this is another case which me and Dr. Manoj Chadda had managed long ago, about 25 years ago. This was a middle-aged man, hypertensive diabetic, came in with very severe backache. In fact, a spine surgeon referred to me because he said that patient is severely osteoporotic, has weakness of thigh muscles. He's been in bed for 1.5 months. All this has been going on for almost 18 months to 24 months. And last 3 months, he was in bed under care of a spine surgeon. You can see he has got multiple fractures. And this was 25 years ago. His DEXA was done, which was, spine was really poor, minus 4.1. Hip was minus 2.3. And he was given calcium, vitamin D as usual, pakka masala by orthopedic surgeon. He was also given calcitonin and bisphosphonates. The other things were not introduced in India till then. The teriparatide, etc., had not arrived on the scene. His calcium is normal, phosphorus normal, vitamin D was normal, PTH was normal. Most of this thing was normal. And this is where we stand. We have severe osteoporosis with multiple compression fractures in a middle-aged person with no response to calcium, vitamin D, alendronate, and calcitonin. Today, whether you would like to give him teriparatide, stroke, denosumab, stroke, whatever. He's in bed for 3 months. Any inputs?
So first and foremost, the only fresh fracture is L4. Let's understand.
Right.
So his present source of pain is L4.
Right.
But he shows telltale evidence of vertebral fractures above that from 12 all the way down, which have happened over a period of time. So there is now a cause for an endocrinologist to step in. He's a man to look for secondary causes of osteoporosis. This is not something which is either nutritional or related to just his diabetes or something of that sort. Beyond the little thing that we know as secondary causes, there's much more that needs to be looked into. And I would not shy away from the fact that I'll call my endocrinologist to see him. So I'm very clear about it.
Yes. You also agree. Yeah. So, yes, please.
Both were the days when I was doing a little bit of osteoporosis, and I remember saying, I'm not going to give the diagnosis of it. But it was a spot.
Yes.
When you examined it, it was
Correct. Correct. Anything else? So, I called up Dr. Manoj Chadda. Somehow I felt that this is steroid-induced. Somehow I felt that he must have taken Ayurvedic treatment for sterility or impotence. That is what I thought. And he did say that he had taken Ayurvedic treatment because he felt a bit impotent for about 6 weeks. But when I called up so any input from the... He told me to do one thing, and that was the diagnosis. Yes. Anything else? Clinical examination. He told me to do one thing. Hey, Vikas, jara ye kar de. Hey, Vikas, jara ye kar de, was his statement.
One basal cortisol will help us a lot.
He said, jara uska पेट देख ली, पेट देख ली, जाएगा आगे. And that was absolutely classic. Next. Yeah. Absolutely book picture. Absolutely book picture. Then, of course,
this is from the Zoom, it's not from the PowerPoint.
What? What Zoom? I don't know.
Someone else has made that.
अच्छा.
कोई और लाइन मार रहा है.
Okay. And then he had a big pituitary adenoma. It was operated somewhere else, but you can see here the big pituitary adenoma. I was told by Manoj that very often it is microadenoma, but then in this case, this was a very big pituitary adenoma. Any inputs?
Then again, sir, my question to the endocrinologist. After how many days of this surgery will the patient improve? Their bone density will improve.
There is a difference for primary and post-menopausal osteoporosis. It is very common. So the machine does not have because secondary osteoporosis, like hyperparathyroidism, you may do it a little earlier. Some have done it within a year. Normally, it's not done in the usual stage. Usually,
So that means here it is even slower than the renal osteodystrophy, the improvement. Acha, okay.
Can I ask a cross question in relation to this to Balki, Manoj, and Dr. Nifsha? So just like we find that clinical improvement of tuberculosis is far better and quicker than radiological improvement on the MRI. This is now accepted, although there may not be classical evidence. I'm trying to share this that, sir, we have given patients teriparatide and romosozumab for 3 to 6 months, severe osteoporotic with a T-score of less than minus 3.5, and operated on them between 3 to 6 months with good quality bone. I'm trying to tell this from the perspective that, yes, we may have to wait for 18 to 24 months to see it translate into documented evidence. But what we are seeing and feeling on table, I mean, I can say this, I don't know about Kshitij and everybody else. Please, sir.
quality might improve much earlier.
So that's where I want you to sort of agree with this, that when we, like Sir showed remarkable healing ability in a young bone, there are times when we would actually wait for 3 to 6 months for an elective spine surgery and translate it into a good surgery with metal put in, provided we gave them that 3 to 6 months only. DEXA में कुछ फर्क नहीं होगा, शायद बिगड़ भी सकता है.
Okay, thank you.
I just again a question to the endocrinologist. He asked me teriparatide, you said, no? Now my question is, from you guys, you are more experienced than us. Sir, 1:1 at 6 months, from what I've read, romosozumab is a neck ahead than teriparatide. So I would just like to know, is there evidence now?
Yeah. That you want to use?
No, at 6 months. Let's say I have got to start a patient. I have my blood relative who's needs a surgery, so I start her on romosozumab rather than teriparatide. Will I be happier at 6 months when I operate?
Definitely.
That's what. So that needs to be conveyed, that romosozumab is beyond, in the first 3 to 6 months, beyond teriparatide. Yeah.
Good morning. So today, thanks the committee for inviting me. This is a little different from the usual talk about the drugs, the anti-osteoporotic. This is more orthopedic talk of how to deal different fracture cases, but there is something to do with endocrinologists also. So this is a gentleman who came, who had a fracture, a road traffic accident, and sustained this fracture. Now, from orthopedic point of view, it's a very bad fracture because it's at subtrochanteric level and it's a very difficult to treat, and generally it is associated with more non-unions, implant failures, and delayed union time. So for the panelist, any mode of fixation, sir?
So this to me looks like an atypical fracture, despite the age, despite the sex. This fracture subtroch 2-part in a young adult at 42 is very unlikely to be a standard high velocity trauma. This to me is an atypical fracture. I may be wrong, but I have that suspicion already.
Correct. Yeah. Because you can see the lateral beaking, you can see it's a non-comminuted fracture, transverse. Yeah. How would you treat it? Means what will be your mode of fixation in this? Nail, plate, Dr. Bijlani?
Yeah. So now we have the understanding that we should do a double fixation, but in 2016, I think this understanding was not there. This should have been fixed by a recon.
Yeah, yeah. So this was not done by us. Yeah. So yeah, correct. Nowadays we are, as an orthopedician, have understood that these fractures take a really, really long time to heal, and we may have to offer other modes or dual mode of fixation. It was not done here. It was done in Delhi, and the surgeon has used this type of plate to fix it. Now, how means what do you expect this fracture to unite, not unite?
So I've heard the term. This is called Dave failure. I think this was basically bound to fail. So either the screws will cut out from the top or the fracture. So either the screws will cut out from the top, or just simply back out something. There is a very high chance that there will be going around. There is no support on the side, and the screws are also very small.
So rightly so.
I have a very stupid question. I'm interjecting. Would doing a bone biopsy at this stage help us from the endocrine point of view? Any sort of bone study at this time to tell us? I mean, we are not knowledgeable enough to diagnose things. Huh? We are orthopedic surgeons. So don't expect us to suspect anything. वो suspect कर लिया, बहुत कर लिया. लेकिन अगर हम कुछ आपको दे सकते और आप बताते कि इसमें फला फला बीमारी है, तो हमें अच्छा लगता.
But when it comes to bone biopsy, I think most of us are not even able to see. Bone biopsy you guys can do.
Interpreting, would it help us is what I want to know. Quality of bone, would it help us to tell us what we are dealing with? Can a metabolic bone disease be picked up to some extent? Okay. नहीं, ये हड्डी नहीं जुड़ने वाली हमको पहले दिन दिख गया है. अब वो उसमें कारण क्या है वो हमें नहीं पता है, वो हम पूछ रहे हैं आपसे.
So rather than going for the bone biopsy, if I may interject, sir. Yeah. So first need the atypical fracture there does not occur right through in a healthy patient. So doing pre-operatively bone turnover markers is one of the things that could have helped you in planning a medical therapy after the fixation. Had it been a dynamic bone disease that is induced by the any therapy, that mapping the bone turnover markers could have helped you, that I'm saying. And similarly, in a renal osteodystrophy also, the mapping the bone turnover markers may help in planning the subsequent medical therapy in the management.
Can you elaborate for orthopedic surgeons? Yeah.
Sorry.
I think, yeah, bone marker will change because fracture.
Yeah. Yeah, it most probably a dynamic bone disease induced by the any bisphosphonates or the denosumab type of therapy that has been there. So if the bone turnover markers are really suppressed because of the any bisphosphonate type of the therapy that he has received, there is a point that you can actually use the osteoanabolic therapy post fixation. Yeah, but and the response can be monitored with the baseline.
When was this patient operated?
So,
When was this patient operated?
2016. So we are suspecting this.
Denosumab that
Yeah,
time.
this patient is a young guy, 42-year-old, with no history of any bisphosphonates taken, with no history. So we are suspecting that the fracture pattern looks like atypical, but maybe just as bad subtrachanteric fracture.
That he's not hurt. So we are just trying to think on something that retrospectively we could have done is all I want to know.
Any other drug or any other substance which can cause increase in bone turnover marker?
In this patient, I would rather expect bone turnover markers to be on the lower side.
Okay, what is the marker maybe?
Then other possibility remains is something like a metabolic bone disease which manifests in the adulthood.
Okay.
If the drugs are not there.
See, you asked the question of what are the other drugs? Okay, so we are getting into the point. Previously, for this kind of fracture, the bisphosphonate all are there. The PPI we are publishing in JBMR 4 cases on pantoprazole 3 years. Okay, so 3 atypical fracture. So the PPI, though it was there in the criteria initially in ASBMR, they have taken off later. Now we are getting into JBMR and saying that PPI is the only, there is no other open, and they are all coming with the atypical fracture. So this
also means pantoprazole is what you're proposing.
all this is pantoprazole.
I'm taking for a how long? 1 year, 2 years?
I have a patient for more than 36 months.
36 months.
So, that is our this thing. So this kind of drugs also. Of course, in addition to what doctor was saying, we need all bone mineral profile, calcium, phosphorus, everything, including creatinine, before making a further diagnosis.
Confusion. There was this confusion about one doctor saying that bone markers karna chahiye, but then fracture mein nahi karna chahiye. Can you a little bit elaborate on the bone markers which you would recommend, like CTX, BNP1, which ones?
Basically, we go for a bone-specific alkaline phosphatase and in the case PN1NP. PN1NP. But again, availability of bone-specific is very, very limited and restricted.
So the thing is, we use bone turnover markers for past 13 years. And so what we commonly use for a bone anabolism, P1NP, which we charge 700 rupees. And for bone resorption, we use CTX, which we charge 400 rupees. Now, in this setting, so this is we had the same problem. We are publishing our hip fracture study. We have done bone turnover. The reviewer is asking, how can you do a bone turnover? So the overall thing is, as they all said, the bone turnover goes up. And when it settles physiologically, by 12 to 16 weeks, it comes to baseline. His point was, in spite of fracture, somebody has got a decreased turnover, then we may indirectly indicate a low turnover state. Otherwise, the bone turnover immediately after fracture, especially CTX, goes up. And it takes it peaks after like 2 weeks, then it slowly start coming. When it comes down to baseline, unless you do an intervention, it will comes to baseline by 12 to 16 weeks, provided there is no other, like a parathyroid, everything is not, they are all addressed proper.
So going forward, the patient underwent a revision surgery. This was all done elsewhere. The previous implant was removed, as well as he has used a longer plate as well as used a bone graft. So all the things have been done, the longer plate, fixation, biologics, put in a bone graft. They have followed everything. Even then the patient was not healing. So this is when he presented to us. He came all the way from Delhi, frustrated, not healing, in spite of 2 revision surgeries, bone grafting, still 9 months after the post-revision surgery. So it's been a long journey for him. Inability to bear weight, still have pain, and there's a fracture site tenderness and thigh muscle wasting. So what now, would you recommend? Would you recommend him another surgery where maybe you will look to have a different type of implant, a condylar blade plate, bone graft, fibular graft? What would you recommend? He's really frustrated. He doesn't want any other surgery, and therefore he has come. He has been advised multiple surgeries all across at various centers, and whenever a surgeon is telling him a surgery, he runs away from it.
So if you are going to ask an orthopedic surgeon, he will recommend another surgery. Right? I'll be very clear with you. He will recommend remove this implant, put an angle blade plate, put a fibula inside, and use RHBMP2. दुनिया का सब कुछ डाल देंगे और फिर वो सडनली उसको याद आएगा कि एक जादू की दवाई है जो मैं गलती से देता हूं लोगों को, जो मैं रोज का इंजेक्शन लगाता हूं, मैं 3 ट्राई क्यों ना कर लूं.
He has been on teriparatide.
वही मैं बोल रहा हूं सर आपको. For a 42-year-old without any specific indication, if you incorrectly or unindicated, supposedly without evidence, used 3 months of teriparatide, then believe me, God bless, off-label कुछ भी हो सकता है.
So he was on teriparatide during this 11 months post-revision surgery. So, teriparatide is not helping him. So what else can we think about? Now we have to think off-label because he is not willing for surgery. So, okay. So this is what we have done and this is what we have published. So this is the first case where we have used Denosumab. And, because the patient was not willing for any surgery, we thought, okay, off-label, like, sir mentioned, off-label, let's try. Nothing wrong in trying it. That's how we thought about it. Okay, let's give and see. And when we looked at how and why it should work, you have different stages of fracture healing, and where you have a stage of bone remodeling, where you see the resorption of the callus. And, maybe Denosumab at this stage, if there is a lot of resorption or anti-osteoclastic activity happening, and because of which callus is not forming, maybe it can help at that stage. And so there are animal studies which have shown, this is when we started looking at Denosumab before prescribing the patient. So when we looked at the animal study, it shows that in the animal studies, it has shown an increase in the callus volume as well as enhances the load carrying capacity and the torsional strength. Another studies where it was shown, initially it was thought that, all those anti-osteoclastic drugs is not ideal. In fact, teriparatide should be given, and, anti-osteoclastic drugs is detrimental to fracture healing. But there are studies which have shown that it is not detrimental. Instead, it aids in fracture healing. However, the dose is different. If you are using Denosumab in osteoporotic dose, it will not work. So, you have to give a different dose. And the dose which has been recommended for bone resorption and bone metastasis was 120 milligrams subcutaneously every monthly. And there are studies which have been used where the Denosumab have been used at that point of time for giant cell tumor, and the doses was 120 milligrams subcutaneously at frequent intervals. So what we actually looked at is repurposing the Denosumab which has been already used for different indications, maybe at a different dose. Maybe we can, try and see if it works. And we gave this patient 120 milligrams subcutaneously monthly for 3 months, along with the calcium and vitamin D supplementation. And you see, the miracle, it actually healed. It actually healed gradually. The one which was not healing, gradually you saw that the anti-osteoclastic drug, the resorption, what was happening because of more osteoclastic activity, it was deteriorated. And, somehow at 9 months, the patient, the fracture showed complete union and the patient was also happy. And this was the first case where we started this. Yeah, where's doctor? Yeah.
The diagnosis actually it was completely a traumatic fracture, and you wanted to say that it healed by Denosumab?
No. I'm going to conclude this, but the point which I am trying to make here, it was a difficult fracture, not that it was a atypical fracture, because there was no history of bisphosphonates taken. However, it was a very difficult fracture pattern, and such difficult fracture patterns also take a really long time to heal, as well as they have a lot of non-union chances. Surgeon has done whatever he could. The second surgery, I will not agree with the first surgery, but the second surgery is done. He has followed the biology, he has followed the principles of the fracture fixation, he has used a bone graft, so he has done all his bits. But even then the fracture was not healing. So there was something to do with biology. So when you have adequate fixation, when you have bestowed the anatomy properly and the biology is an issue. So then we started looking at the biology could be the reason and how to help the biology. And, off-label, we tried that and, it worked.
So did you stop the teriparatide and then start the denosumab?
Yes. So another case, 18 months post-surgery, there was callus, but it was not bridging. So we gave the injection and it showed that, the callus is forming. So abundant callus formation, the fixation was adequate. It is just that, even after 18 months, you still see that the, callus is not bridging. So you are seeing that the callus is forming, the fixation is adequate, but it's not able to bridge. Maybe, the osteoclastic activity is letting not the callus form in abundance so that it bridges. And this is when we gave and, it healed.
So Mayank, one more doubt is here, especially in the last case, which you showed just now, which you showed, that he healed after 1 year, is what you're showing. I have basically, and is young patient again?
Yeah, this was a young patient.
This was a young patient. So, Agashi sir, what is your opinion? This would have anyone healed whether you have given denosumab or not after 1 year?
Honestly, I was deadly against this concept that denosumab would help or heal. But we have 3 cases where day 1, they started denosumab. I was sure that this surgery, it cannot be without surgery. And follow-up, they have shown that the fractures have healed. So I cannot challenge that success. Though on principle say that it is very unlikely, but these 3 cases they just proved that in some cases, it's a very dangerous thing to initiate denosumab or any drug for fracture healing. However, the indications have to be perfect, that the fixation is good, mechanically there is no problem, the fracture is throwing callus but not bridging. So it's a very narrow sort of indication. Then I think this would work. So not otherwise. See, if the fracture has not healed for 18 months, then I would say, because that was generally at 9 months, we would say it is non-union and some intervention is needed. At 18 months, the fracture had not healed and it healed after denosumab. So it's very, very, I had to change my opinion, is what I can say. However, all I'm trying to say is people should not blindly follow it, that it is used. Nahi judta hai, chalo denosumab denge. That's a very dangerous thing.
So since we're short of time, I'll just conclude it, and then, there are a few more cases which were there. So what, like Gashi sir mentioned, even we had the same thought process that it should not be used for any case. It should only be used when you have, as an orthopedic surgeon, you have adequately fixed it. The biology is good. The callus is forming. It is just that the callus is not abundant and is not able to bridge. Should not be used on any fracture cases where you feel, okay, if I have not fixed it well, I should give denosumab. It doesn't work that way. It works only if you have adequate fixation and the callus is forming, but it is not in abundance.
So, yeah. Yes.
Yeah,
have been very high doses to all these patients. What about follow-up of these patients? Have you given them bisphosphonates and then because see after denosumab there is a lot of osteoclasts which are increased inside the cells, so that might increase the chances of high bone turnover in once you enter the denosumab.
So just a different answer. We are orthopedician. Fracture heal हो गया, हमारा काम खत्म हो गया. So we have not followed up what has happened about the bone markers. But we have followed it in terms of the fracture union. We have not done the biomarkers. We have not checked what is happening about the BMDs.
So maybe know from the esteemed colleagues here. So what is it that can go against us? I wish to know. I'll be very frank, sir. Sir, again, I'll tell you why. Sir, you have right now shattered Dr. Agashe's belief. Fine. And no shattered because he believed it won't work and he saw it working. So three cases have shattered his belief. But I also go a step forward that beliefs are not truths. Beliefs are tools and they need to be modified. So do we need to modify our belief and are we safe enough in using it in the present dose? इन्होंने 120 per month for 3 months दिया है. हम लोग GCT में 120, 0, 7, 21, 28 पे देते हैं. यानी इतना ज्यादा भी देते हैं.
So I think Ram, take the last question first.
हाँ जी.
The dose.
Yeah.
When you're using it for a short period, it doesn't matter.
Fantastic.
You used it for longer periods with problems. So 3 months.
Tell us the problems.
No. So let's not go in that today. It's different problem. But 3 months, 4 months, 6 doses really doesn't matter. Whether we need to change our beliefs, this is a beginning. See, science is not black and white. There may be things which we really don't know yet, and they've made a beginning. I was just talking to Girish. Tomorrow, is it going to become a standard of care that after you've done a good fixation, a short course of XYZ drug? So today it's not there, but someone wants to do it off label with ethical clearance. I think we should have ethical clearance for it from our review board. It gives you that comfort.
So we for years, when Dr. Agashe was teaching us, we believed that fracture heal only with compression. Now the whole world says fracture can heal with distraction. Am I right, sir? We learned it.
Yeah, we learned it that way.
I have one query. I don't understand much about the bone or nor how these agents work. But we know for a fact that all orthopedic surgeons who deal with large tumors related to the bones, huge, they use large doses of denosumab to curtail the vascularity and the size of the tumors. So definitely denosumab is doing something. And maybe where there's callus formation and no breathing space.
And increased calcification. The strength of the bone increases when we are dealing with tumors. Yeah.
Recent recommendation for population regarding osteoporosis treatment for surgical fixation. So they have found that for osteoporotic, they benefited from using these agents. And the patients who had normal bone density did not have benefit. So this was some paper which was published. Recommendation is there.
So one just additional thing I would like to say that moment this becomes popular, it would be a very dangerous period because today teriparatide is extensively used by orthopedic surgeons for fracture healing. And that's even if the fracture fixation is not very good, teriparatide is used, which is a little dangerous thing. That's all. I hope the denosumab doesn't follow that. Yeah.
So, thank you everyone for this wonderful session. Thank you to all the orthopedicians for coming here and interacting with us. Thank you to the chairperson. And before we get late, we are moving on to the next lecture. Thank you. Yes, sir. No, sir, it was our pleasure. Thank you. Thank you for coming. So, for the next lecture, I would like to call upon the two chairpersons, Dr. Kavita Krishna and Dr. Fulrenu Chauhan. So, Dr. Kavita is a professor and head Department of Clinical Immunology and Rheumatology at Pune. And she has had many achievements to her credit, over 140 publications, Best Paper Awards, President-elect for the Maharashtra Rheumatology Association. We welcome you, madam. And we have our very own Dr. Fulrenu Chauhan, consultant endocrinologist at Hinduja Hospital, who is also the head of the Type 1 Diabetes Project at Hinduja. She has many national and international publications and is our guide and postgraduate teacher. Welcoming you, madam. And for the next talk, I would request them to introduce Dr. Balakrishna, sir.
I think as is always said about people who are well known, I don't need to introduce Balki as we call him. And rather than his name, which is well known for rheumatology and osteoporosis, I must add that he's a fantastic dancer. And we go into splits when Balki dances, and he's a fantastic cartoonist. So, and a singer too.
So apart from a doctor, I'm everything else. Thank you. So I was involved with osteoporosis, like I said, when I went to Bath. That's where I trained after I went from Dr. V.R. Joshi, working with him for 3 years, and that had a separate osteoporosis clinic. So I used to do the clinic for 3 years. And Bath was the place where all the first bone densitometry ever came to UK, Royal National Hospital for Rheumatic Diseases. And there was a professor for bone densitometry there, Professor Francis Ring. And he was the one who taught me how to read DEXA. So those were days. And I came back, but the number of rheumatology cases were so many that one couldn't really focus on one disease. But now the number of rheumatologists and trainees have increased. So slowly people are branching out, which is nice to see. So I'll start, and I'm going to take a topic which is a little different. I have a lot of orthopedic surgeons here who can also pitch in and give their views. Thoracic vertebral fractures and their importance. It's not moving. Okay, thank you. So the thoracic vertebrae, as we all know, it has a slight convexity, concavity towards the anterior aspect. The rib cage is something that also buttresses the thoracic cage. You have the ribs going back in thoracovertebral joints, which hold on to the vertebrae there. So the rib cage is often called the fourth column. Normally we know about 3 columns in the spine, but rib cage acts as a fourth column. It's a little bit stiff when compared to many other spines that we come across. And it's important to know this. And they make up for about 20 to 30% of all spinal fractures. So thoracic vertebral fractures make up 20 to 30%. And this is again the anatomy in one of the old anatomical drawings done by hand by somebody. And you see the facets, the superior and the inferior facets are also placed a little differently from other vertebrae, as the spine surgeons would say. And it has a long spinous process which goes down like this, more downwards. And it's like tiles, one tile after the other. So it prevents posterior entry of injury into the spine. So it's a very nice way of taking care of the spine. So that's the anatomical part of the thoracic spine. And these are the clinical features of a fractured thoracic spine. We all know about the stooped person who comes to us in the clinic, and the pain in the whole or part of the back is there. The pain in most of the times in patients with osteoporosis is not because of osteoporosis. If somebody has a very painful osteoporosis, you need to look for secondary causes rather than blame the osteoporosis for the pain. Oftentimes the pain is chronic, and that's because of muscular pain. The straight spine has become bent and the paraspinal muscles are all stretched, and that causes a lot of pain. And therefore extension exercises are of more importance, especially after the fracture is healed, which many of us don't ask the patients to do. It is very, very important to get the pain down. Breathing difficulties and gastroesophageal reflux, feeling of fullness because the rib starts going towards the pelvis as more and more thoracic fractures occurs. So these patients are not able to eat much. They end up eating more frequently rather than the breakfast, lunch, and dinner because the space is less for the organs in the tummy. Kyphosis, all of us know about, loss of height, tummy bulges, and a clinically diagnosed fracture. These are the usual well-known features of thoracic spine fractures. The causes, the commonest cause is still an osteoporotic fracture. I'm not saying no to that. And there are two areas which often the fractures occur. It's the T12L1 probably is the commonest because that's where the maximum strain of the whole body weight falls in the spine, and they are the ones that fracture commonly. And also T7, T8 would be the next group where you can see fractures. So the commonest cause is an osteoporotic fracture. But the reason why I'm putting this talk across is for us not to forget pathological fractures and how to pick them up. And that's, I think, the most important point of my doing this study. I mean, this talk is that these are the things that I would not like to miss. I wouldn't want to call everything an osteoporotic fracture. I would have enough in my mind to think of other things as well when a fracture occurs, how to pick it up, what to do for it. That's the main thrust of my talk. So the differences are also there. As far as osteoporotic fractures are concerned, it's said that lumbosacral, I mean lower thoracolumbar fractures and lumbar fractures, is usually a trauma, but thoracic fractures, it's the frailty itself that can lead to a fracture. Oftentimes we don't get a proper history of an injury or fall or anything in these people, and 50% of these fractures are silent. So that's why if you have somebody with osteopenia or osteoporosis and you feel that there is a little kyphosis, if you do just a lateral thoracic X-ray, you'll pick up a fracture which was very silent. And from just an osteoporosis, the diagnosis changes to established osteoporosis because there's already a fracture there that has a different meaning. So doing a simple X-ray of the back oftentimes, and oftentimes also the bone densitometry, if a good lateral one, you can pick it up. And nowadays we are talking about looking at those fractures there, and there are good ways of giving the criteria are there, what to call them as fractures. We'll come to that. So that's important. So presence of severe fractures predicts subsequent hip fractures. We have always been taught that fracture at one particular site is the best predictor of another fracture at that site. If you have a vertebral fracture, it's the best predictor of a vertebral fracture. A hip fracture is the best predictor of, but this one is very important. A severe vertebral fracture goes beyond its limits, and it is a good predictor of a hip fracture. That's an important thing to know. So this is the usual. In the past, we used to call just a loss of anterior height, burst fractures. Many terms were given, but they're all gone, and you have to classify the fractures based on what is given here. Based on the anterior, middle, and posterior height, you have normal, mild, moderate, and severe fracture. There is nothing else. No other terms need to be used. And if it is 20 to 25% reduction of, let's say, the anterior height, it's mild. 25 to 40% reduction, it's moderate, and more than 40%, it's a severe fracture. So we are talking about severe thoracic fractures. More than 40% reduction either in the anterior, middle, or posterior heights predicts hip fractures. So it's a very important thing to pick up. Subsequent mid-vertebral fractures are less likely, but we cannot predict. And apparently, studies have not shown that. But although we are always taught a fracture always predicts another fracture at the same site. This is very important. Almost 1/3 of thoracic vertebral fractures are pathological fractures. So therefore, please be very, very, if you have just a thoracic fracture coming to you, be extremely vigilant. Whatever the age, especially if it is young, be extremely vigilant that this could be a pathological fracture rather than your usual osteoporotic fracture, although it can be that. And features favoring pathological fracture as this: fracture with significant bony destruction, but this is possibly the most important, the second line which I've underlined here, which we can see in simple X-rays, AP and lateral. Because if you can get into the habit of reading these X-rays properly, especially the AP X-ray, wherein you keep looking at the pedicles as owl eyes all the way through, you have to always go through them. Very surprisingly, you'll find that in osteoporotic fractures, the owl eyes are maintained because most of the osteoporotic fractures are anterior, affecting the vertebral body. The minute the owl eye is gone, it's posterior, the pedicles are involved, and you're thinking more and more in terms of a pathological fracture, a secondary cause, rather than blaming it on just pure and simple osteoporosis. So that's what it is. Convex bulging, which I'll show you, the posterior vertebral cortex, epidural or spinal mass. These are all giveaways. This has gone a bit too long before you think of second, because this is very typical, and other vertebral metastases that are there.
So malignancy and fracture, one of the commonest causes of pathological fractures are malignancies, and metastases are probably commoner than primaries in the bone there. So of the metastases, these are the ones very important: lung, breast, thyroid, renal, and prostate. We have the prostatic cancer is one of those which can cause both osteolytic and osteosclerotic mets that you can see. So both can be seen. Multiple myeloma is not an uncommon cause of vertebral, especially thoracic vertebral fractures. And if it is a primary, it's usually primary osteosarcoma, sometimes Ewing's. I think you can get in the vertebral body, but these are the usual things that you look for. So how do they cause bone destruction? We all know that cancer cells reach the spine through the Battson's plexus, a network of veins, which you can see here in this diagram. Since these veins have no valves, they can easily move from malignancies in the abdomen, pelvis, and go into the retroperitoneal, into the vertebrae. And tumor cells in the spine release PTH-related proteins, parathormone. This protein activates a pathway called Rankel, which all of us know about. And Rankel pathway activates osteoclasts. We discussed this yesterday as well, which is very, very important. So that's the pathway, and that's how the bone damage and everything occurs. So this is the winking owl sign, which all of us are taught to pick up. You go on watching this eye. This is the eye. You can see eye here, eye here. You can see eye here and eye here. But here, the right eye is winking. So that tells you immediately that it's a... So get into the habit, all the registrars, students here, get into the habit of reading X-rays well. Go through the anterior line, the middle line, the posterior line, AP, lateral. They're very simple and easily obtained, but often not read. Many radiologists also miss, but if you can get into the habit of reading them thoroughly, simple things you can pick up even on X-ray and do the next step that will be necessary. So this is the Winkel and this is posterior elemental involvement. And this is just a comparison between the usual osteoporotic fracture. I've told you about the AP view where the facets are gone and the winking eye is there. This is just a lateral view. You can see this is the MRI here, which shows how the bones are maintained. You can still see the normal looking whitish bones on T1, and that is totally replaced by something black here in T1. And there is a bulge posteriorly going on. So the bulge sign, the loss of the usual features of the vertebral body on that particular imaging, T1, T2, whatever it is, all should make you think in terms of a pathological problem. And osteoporotic compression fractures are like this. There's not much posterior bulge or anything happening here. So this is important to pick up. Myeloma is a little different from usual METs. Myeloma, in the sense, has more propensity to involve the body rather than the pedicles. So pedicles can be involved, it's more of body. So punched out lytic lesions, look for well-defined dark circular holes in the bone. I'll show you some. Bone marrow-eating cells destroy the bone, causing clear-cut areas. So you can see these lytic areas that all of us know about. Usually the bone scans may be negative because there is no new bone formation. Bone scan usually pick up the new bones that are coming up, osteoblastic activity. So bone scan is not a good way of finding out for myeloma. It will be negative in many unless the fracture is healing or something and you get some osteoblastic activity. Vertebra plana is something that we see in severe osteoporosis, but very, very typical of multiple myeloma if you see it. And this is a medical term, vertebra that has been crushed completely. I'll show it. Generalized osteopenia, we all know. And again, this will be osteopenia with pain. So painful osteoporosis is a very, very important thing. Don't ascribe it to just osteoporosis. Myeloma, osteomalacia, hyperparathyroidism, METs, all of them cause painful. Also, painful osteoporosis, look for a secondary cause always. Before you say it is only due to osteoporosis, unless there is a fracture, which can explain it. No new bone growth. Many times myeloma, the fracture, there's often no new bone. Unlike other cancers, leaves no white hardened ring around the fracture, which is also a typical feature of myeloma. So here you can see these are the osteolytic lesions that are seen. Look at here, one anterior, posterior in the bone, more of the vertebral body. And this is the vertebra plana that I spoke about, the totally crushed vertebra that is seen here, which can occur in any severe osteoporosis, but more so in a multiple myeloma. So keep that in mind. You can see the MRI picture. The next important cause of secondary causes like pathological fractures is infections, which are not uncommon at all in India. Infections, usually early stages, the X-rays will look almost normal, but over a period of time, disc space narrowing, end plate irregularity, and deformity will come. These have to be picked up on a simple plain X-ray, but by that time, the use of MRI has gone up exponentially over the last few decades. So the patient almost always has an MRI with him, which helps you. But later, if you don't have it, your eyes should be sharp enough to pick these things up even on a plain X-ray. So that's one. And this is just a cartoon to show what all happens. This is the normal disc. And it's mainly an osteomyelitis that is occurring in the bone. Usually it starts with the body many times and goes posteriorly to involve the pedicles as well. And it also presses on the cord, which you can see here, the normal cord getting pressed here. Epidural abscesses. Oftentimes these abscesses also track down into the, you go into the muscles around it, and you start getting involvement of the muscles downward. So vertebral osteomyelitis, epidural abscess, and involvement of the disc. This is a very, very important thing. There are a few differences between bacterial osteomyelitis and TB osteomyelitis. Bacterial osteomyelitis, the end plate destruction is quite fast. It is said that osteolytic enzymes are much more in usual bacterial infection than the mycobacterial infection. Therefore, early destruction occurs of the end plate, whereas in TB, the end plate destruction is much, much later. And so you have the abscess, adjoining muscle involvement. The psoas involvement is something that all of us know, and psoas, how they come to us with flexed hips, and they're very painful and they can't walk well. Neurology also occurs reasonably faster in bacterial. End plate is involved later. Discal involvement and adjoining to vertebral involvement is something very typical of TB. Adjoining vertebral involvement, psoas abscess too, because over a period of time it is there. And another infection that is often missed and not thought about when there is a spine, they're always thinking of TB, but we forget brucella, which is also an important cause of osteomyelitis, sacroiliitis, unilateral sacroiliitis with an abscess. So that's another infection we often miss. So always think of it when it's atypical, when you're not getting the organism. 9 out of 10 times it will be TB, but once it could still be, in the right clinical setting, it could still be brucella, which is very, very important. Always, so this is very important that you learn from your radiologist. Other than a plain MRI, if possible, always do a contrast MRI. That picks up abscesses much better than your plain MRI, and you know what to do with them, and the spine and the referred spine surgeon or the orthopedic surgeon knows what to do with them with a contrast MRI rather than a plain MRI. So I've come to the last part of my talk. I didn't want to bore people a lot. I know it's 25 minutes, but I don't want to talk for that long. So although osteoporosis is the commonest cause of thoracic fractures, the prevalence of pathological fractures is more when compared to lumbar or cervical spine. So that's something that you have in mind. Involvement of the posterior aspect of the vertebra should alert one of pathological fractures. Think of the winking owl sign, and the further imaging will show an abscess, will show involucrum, will show everything, and that's something that you know. Presence of abscess, involucrum, suggestive of infection. Contiguous vertebral discitis and late involvement of the end plate are all suggestive of TB. Thank you very much for the patient hearing, and I would ask the orthopedic surgeons and the spine surgeons here, maybe they can add something. Thank you.
Yes. Dr. Bhavin Zankaria was a very famous radiologist, made a statement in orthopedic meeting that sorry? No. Acha, go on the stage. Okay. Dr. Bhavin Zankaria, who is a very famous radiologist, was speaking in an orthopedic meeting. And he said that the only subspecialty people who can read X-rays are radiologists. Or rheumatologists, not radiologists or orthopedic surgeons, only radiologists. Thank you. Rheumatologists.
Thank you, Dr. Balki. Excellent lecture. Could you just tell us a little bit of chalk stick fractures also? Chalk stick fractures, I thought, was in ankylosing spondylitis, thoracic spine, though we don't see much of bamboo spine anymore.
Yeah. Acute increase in pain in the spine in a patient with ankylosing, especially a long-standing ankylosing who has a fused spine. We think of fractures, infections, and discitis, Anderson's lesions as they call it, and these fractures are also the ankylosing spondylitis people also have osteoporosis very early in their disease. There have been elegant studies in the 80s and 90s where bone densitometry studies have clearly shown where even when fusion has not taken place and there's inflammation in the spine, they have significant osteoporosis. The reason being both inflammation, the cytokines that are causing it, the Rankel and everything, and also immobility due to the inflammation. Immobility is not only because of in this syndesmophyte formation and fusion, immobility is also because of the inflammation. So therefore, yes, those fractures are seen, they are rare, but they have to be picked up when there is an acute increase in mid-thoracic pain in a patient with ankylosing spondylitis, because the whole spine acts like a long bone. But it's a brittle long bone and they break pretty easily. And they're very amenable to surgery as well. Many of our patients, along with the fractures, come with a lot of stoop. They have lost their height and they have difficulties in day-to-day life. Some of them are so bad that they are not able to see in front. So the spine surgeons here at least are doing a lot of work. They do osteotomy, corrective osteotomy, and straighten them up at the right place. So that, and also fix the area if it is too mobile and there is a risk of neurology later on. So this is done by.
Another important issue is management of this type of osteoporosis, secondary causes like infection, malignancy. So we do not go by the same, like, teriparatide with tuberculosis, spot spine, or even the zoledronate doses. So how is the management of thoracic spine fractures if they're not osteoporotic?
It depends on whether they are in that. If they're not osteoporotic, you just treat the spinal fractures and treat disease that is causing the fracture. That should do. But if they have a second osteoporosis in addition, if this was let's say a 60-year-old postmenopausal lady who is on whatever steroids but has a TB in the spine, there you also have to, depending on the risk factors, the FRAC score and everything, you have to treat the osteoporosis as well.
So can you give teriparatide in a tuberculosis of the bone, or
if the patient needs it for a secondary, the osteoporosis, which is also severe, not related to the Angst-Pond or TB, you may have to give it. There's no harm in giving it, provided you're sure that that is also there.
Okay. And zoledronate doses are different if it's multiple myeloma or
they give it much more frequently. Both zoledronate and denosumab, the surgeons the oncologists treating it give more frequently. Zoledronate 4 milligrams and 5 milligrams both were available. 4 milligrams came first for the malignancy part, 5 milligrams came for osteoporosis. I don't know why that 1 milligram made such a big difference, wherein one you could give once a year, the other you could give 3 monthly or 4 monthly. But that's how it stands, that the 4 milligram was given almost 3-4 monthly, and the 5 milligram is given yearly. And denosumab also they use every 3-4 months for METs and bone pains. Yeah, much higher doses as well. Yes. Yes.
Any other questions from the students or the audience?
So, like you said, that these the myelomas with fracture, they resemble the benign osteoporotic fractures very much. And when you have an elderly person with a fracture and you are trying to investigate the secondary causes, would a thoracic level localization prompt you to do a workup in a different way than a lumbar spine? Let's say like getting serum protein electrophoresis on the get-go day one for a thoracic, where you wouldn't do that normally for thoracolumbar fractures.
Yes.
Or would you do it?
There are a set of labs that we are meant to do even in an osteoporotic fracture, because we cannot, we need to pick these up early. Early myelomas and early things might be difficult to pick up unless you do it routinely. So there are a few things which we ask for. If somebody is 60, 70 and getting fractures for the first time, apart from the postmenopause, if it's a lady, postmenopause, or senile, if it is a male, if hypogonadism, these things we have to check for, including we ask for a protein electrophoresis in that group of patients, always, especially the ESR is a little high, 40, 50, we ask for them. If it is very painful, we ask for
So it's your first set of investigation
in that subgroup, in that age group where we need to pick these up.
And is it possible that you may have an abnormal serum protein electrophoresis and not have all those crab signs like no calcium raised, ESR raised?
It can happen early because the body, the endocrine system, like the endocrinologist will tell you, balances things to a great extent till it breaks the barrier.
Decompensates.
I tend to do serum protein, like I can speak. Serum protein electrophoresis for all my patients when I'm suspecting thoracolumbar or a thoracic, thoracolumbar or a thoracic, give the number.
So means every patient it become.
For non-specific, unexplained back
Back
pain in
pain.
the elderly. And there is an entity called MTUS.
MGUS, yeah.
This monoclonal can
Yeah.
unknown significant, but that's not our job to say. Let the other guys say it after we send the patient to them.
No, I have not been doing it routinely for every fracture, but like we get a set of investigations and then depending on the clinical profile and usually a thoracic level or this level isolated fractures would prompt an MRI, whereas not all osteoporotic fractures really need an MRI diagnosis, but thoracic level actually should get an MRI.
Plain blood test that they come with also give you a clue.
Yeah, you have anemia, you have
globulin gone down, little ESR, the globulins are a little
Yeah.
high. So that there are clues. Creatinine is little on the border. So
oncologists really look at all these tests and are able to diagnose.
no, even rheumatologists.
Yeah, and rheumatologists are the stars, like Dr. Jankaria said, they are gods.
On that note, we'll be closing this session.
Just one comment for.
Yes.
Hi friends, I'm Dr. Parag Sancheti, Chairman Sancheti Group of Hospitals, and it's my proud privilege to invite you for the current Office Orthopedic course, COOP 2026. This
You
will be held
must
on
do
1st and 2nd August
evaluation
at the
for
Grand Hyatt in
myeloma.
Pune,
Yeah.
and it is being spearheaded by our own Sancheti alumni, Dr. Kiran Shetty. This course promises to be of immense educative value for various non-operative modalities of treatment for different orthopedic conditions. And this will be attended by a galaxy of international and national faculty who will answer all your queries.
On that note,
There are
we'll
also
close the
multiple
session.
pre-conference
Thank you,
workshops which will be
Dr.
held on
Balkrishna
21st
sir,
July,
for that
and we are
excellent
going to
talk.
have
Thank you to the
rehabilitation
chairpersons.
orthophysics
And
360
next,
workshop
we have a
held at
very
Sancheti
interesting
Hospital.
panel.
So all of you,
For
please
that
register
panel,
soon.
I
There are
would
few
like to
seats
call
left for
upon
the main
Dr.
conference
Sandeep
and
Yadav
also few seats
and
left
Dr.
for the
Kirish
pre-conference
Parmar.
workshops. I promise
Dr.
you, you
Kirish
will not
Parmar is a
regret. All
consultant
the best to the
endocrinologist
team,
at
COOP
Nanavati
2026
Hospital.
and to Kiran Shetty as well.
We all are very aware about how accomplished he is. He has had many research papers. He's been the former treasurer of Maharashtra Endocrine Society, and he's a founder member of the TriSide Group. Welcoming you, sir. And we have Dr. Sandeep Yadav. Sir is a rheumatologist at Hinduja itself, and his research interests include nephritis, fibroid disorder. He has publications to his credit. So I would request Dr. Sandeep to kindly introduce the panelists for this session.
Thank you. We start with our next session. And for the panel, I want to first invite Dr. Kshitij Chaudhary, sir. Dr. Kshitij Chaudhary is a consultant spine surgeon at Hinduja Hospital, and he was the one person who will go to whenever we have any spine issues. And our next panelist is Dr. Uday Phadke, sir. He is a director of endocrinology and diabetology at Sahyadri Hospital Group of, and we listened to him yesterday, and he had a very insightful to multiple disease as such. And I have asked Dr. Kirish Parmar to join the panel. I also invite Dr. Balakrishnan sir to join the panel as such, because we don't have Dr. David joining us today because of some medical emergency. So thank you, Dr. Balki sir, for joining the panel. So, and also invite Dr. Kavita Krishnan madam to join the panel as such. Come. So we have one more. Yeah. Okay. Okay, so in this session, probably we'll start with some garden variety of cases in which we'll start from osteopenia, then probably fracture on normal BMD, and slowly we'll move on to some difficult cases like atypical femur fracture, and then I will move on to some very difficult to treat and treatment failure fractures. So for the first case. The first case.
So, good morning, everyone. I'm Dr. Ravina, first year endocrinology resident. So this is a case of 62-year-old female with a BMI of 22.2 kg per meter square. Postmenopausal since 50 years of age, came with a complaint of occasional dull aching, low back pain after prolonged standing, and this is relieved by rest. There's a history of sedentary lifestyle and also a history of hip fracture in the mother at the age of 70 years. There's no history of recurrent falls or of fragility fractures, or no history of any long-term glucocorticoid use or any other drug, no history of renal calculi, and no history of other comorbidities like diabetes, thyroid, chronic kidney disease, liver disease, or rheumatoid arthritis. These are her lab parameters. With HB of 10.8, creat of 0.8, with the sodium potassium value of 141 and 4.2, calcium 9.3, ALP of 86, fasting blood sugar of 92, HbA1c of 5.3, vitamin D level of 24, TSH of 2.1, and intact PTH of 46. Her DEXA scan showed at lumbar spine the T-score of -2.2, at femoral neck of -2, and total hip at T-score of -1.9.
So I want to open the discussion on this case with Dr. Uday sir. So your approach to this case.
So the part here is that we have a lady who is postmenopausal with a low bone mass, not yet fitting into a classic osteoporosis diagnosis because of the bone density thing. Now, the whole question is, what should we do? And this is a situation which we come across very commonly. Very often people are randomly given treatments. Very often people are told not to give treatments, and we need to know exactly what to do. There are some positive things here, which means that most secondary causes have been ruled out. She does not seem to have any specific disease. Thyroid, parathyroid, other markers have been ruled out. Now, as has been repeatedly stressed, you cannot ascribe pain to just a low bone density. And if you have pain, it means that there is either a small fracture there or there is a muscle pain. And in a person, particularly where we are dealing with a borderline bone density, apart from the usual, so you would put it into a DEXA, into a frac scoring and find out where we stand. But, even without calculating it, it will not really enter the criteria of more than 20% or more than 3%. Although that is probably not completely sacrosanct for Indian guidelines. And there is work from Christian College also, which has looked at, lower, say instead of saying more than 20%, more than 9% risk could sometimes trigger a response, not necessarily for pharmacological treatment, but for some intervention. So just a frax does not tell us things. This is a postmenopausal lady. She has pain. There is a history of hip fracture in the mother, which we'll have to take into consideration. And then this is a typical case where apart from frax or apart from a BMD, we would be looking at a vertebral fracture analysis or a TBS, because otherwise things will be very arbitrary, especially if we look at vertebral fracture analysis and we find that there is a microfracture. It would immediately classify her into a pharmacological therapy. And if suppose everything is negative, then I would just watch her and see what her density progresses and what happens over a period of time.
So is there, how much is the importance of family history of fracture in this kind of cases?
It is important. And it is clearly important that there is a maternal history of hip fracture in a first degree relative, particularly mother or parent. So it is important. It is one of the risk markers that you would assess to decide whether, there is no, when there is very severe osteoporosis, the situation is very clear. There is no controversy. But in these kinds of cases, you will have to try and decide which of them would really need therapy.
Okay.
Because ultimately, any osteoporosis therapy can be given only for a limited period of time. And you don't want to rush into things and mess it up. So probably more use of VFA, TBS, especially in such cases, would help because the biochemistry is completely normal.
So my next question to Dr. Girish Parmar, sir. So is there postmenopausal osteoporosis is different than senile osteoporosis, or is it basically the nomenclature that is different?
So yeah, the postmenopausal osteoporosis is definitely different compared to senile osteoporosis. Postmenopausal, as the name goes, is because of purely estrogen deficiency, more involves the trabecular bone, vis-a-vis senile osteoporosis, where you have involvement of both trabecular as well as cortical bone. It's age-dependent, gradual slowing loss of bone mass. So definitely, both are different.
Postmenopausal probably may be more severe as compared
Definitely.
to senile and
Yes, postmenopausal is mainly osteoclastic driven,
Okay.
trabecular bone involvement, whereas senile would be more of osteoblast activity going down with age and therefore involving both formations. Severity wise, obviously, postmenopausal would be much more.
So this brings for the next question. The FRAC scoring which we do in osteoporosis basically depends upon the normative data of the particular population. So we have selected the for Indian patients as such. So is this accurate enough, or probably we need more normative data from the Indian patient to actually justify probably we are definitely different than them. So
we certainly do need country specific guidelines.
Correct.
Because the bone quality of India may be very different from what we even see in, say, we are assuming that Singaporeans are equivalent to Indians, which probably may not be happening. And probably Indians are fracturing at a higher BMD than reported. So our trigger to action may be actually heightened if we have India's specific data, but we don't right now.
So as far as risk stratification is concerned, basically looking at this patient with a borderline BMD, so probably the bone markers like CTX marker, do you place somewhere in this scenario? Will first advise looking at this patient, or probably say no, first treat if doesn't improve? So is this an indication probably borderline to look for CTS marker and then decide on the treatment? Does it have any impact?
I don't think I'll see. Obviously, there is resorption going on. Otherwise, the bone density wouldn't reduce. So, just going by a CTX, at least in my understanding, would not help. I think we'll be more helped by doing a VFA, TBS to find out what's going on and observing this patient. So, you have said that she is sedentary. We don't know what her calcium intake is. Vitamin D is borderline low. She has some anemia. So, well, we can look into this and correct it. Give her some impact exercise, calcium, vitamin D, look at her in 6 months, a year, see how she's going, and then probably treat. Just because CTX is mildly elevated, putting her on, how long is the question? She's 62. So
Yes,
she still has life expectancy. So rushing into pharmacological treatment just on one single report like this is probably fraught with.
So probably, thank you, sir. So probably we are looking into something which should fit the pattern. So this brings us to the fractures on normal BMD.
So I think before we go on to that,
any comments? Sir?
Yeah, I wanted to.
Yes, sir. Yeah.
I think when we talk about FRAC scoring, I mean, we all know that it's Indian living in Singapore, and based on that, the data is there. I think we have Thomas Paul, sir, over here. So would you talk about your study and what your thoughts are, especially with the Indian data?
We have 3 studies looking at FRACs and FRACs plus from the urban as well as rural Tamil Nadu. What we found was when you use this data, we are talking about when you compute against fractures, they fare with a 10 major osteoporotic cutoff and 2.5 for the hip fracture cutoff has got a sensitivity of 80%. And the specificity standing at 50%. I thought it's fairly okay to start, as Dr. Balki was saying, the importance of fractures. So it is at this point. Of course, I agree that we need a normative data. Whatever the ICMR data which was produced in 2010 as a normative data for the BMD is absolutely useless. Yeah.
So I actually referred to this study from Tamil Nadu saying that we'll have to use a lesser major osteoporotic fracture risk of about 9 to 10% rather than 20%, and 2.5 instead of 3, which actually increases our, kind of lowers our threshold to look into treatment.
So we should decrease the threshold of the.
We don't have a guideline yet, but from studies, it looks like that for sure.
Thank you, sir. So we come to the second case now.
That is still not going to solve the patient pathway. So that's
Hello, good morning. I'm Dr. Hinduja from the Endocrinology Department, and I'll be presenting a small case capsule. So 70-year-old female with a BMI of 34.2, post-hysterectomy 20 years ago, known case of diabetes, hypertension, dyslipidemia on treatment, and now presented to us with history of slip and fall in her house, followed by lower back pain, which was continuous and increased on movements. Her X-ray was suggestive of D12 osteoporotic compression fracture. She used to take calcium and vitamin D3 on and off, and no other significant history. These were her lab parameters. Her sugar was not very well controlled, but otherwise her bone profile seemed okay. And this was her BMD DEXA scan. As you can see, the T-score at the AP spine was minus 1.5 with a BMD of 1.004. And even otherwise, her DEXA was not suggestive of osteoporosis. So in such a case, what would be the further management?
Thank you. So this is another garden variety of case when we have a fracture on the normal BMD. So two things I want to understand. I definitely want to understand the management here, but from Dr. Kshitij Chaudhary, I want to understand two things. The first thing is, how do you acutely manage the pain in this scenario? So can you comment on that part?
So the
X-rays, we don't have the X-rays right now, but suppose it shows T12 compression fracture.
So the usual, you are saying garden variety. So let's assume that it is like a usual compression fracture.
Yeah.
So the principle of management, acute management fracture is try to control the pain and try to get the patient out of bed as early as possible. Many people give too much prolonged bed rest to the patient, like 2 months of bed rest, which for an elderly person is really not so great thing. So maybe a few days or a week or two status is fine in the bed, but the earlier you get out of bed, the better it is. For that, you require adequate pain management, which would be combination of medications which the patient can tolerate. You can go up to narcotic level medications as well. We prefer like Buvalar patches and things like that. Depends on the side effect profile and the patient's medical condition to tolerate all those medications. But pain management is a big factor because there is fear involved of movement for these patients. So because they are in so much pain, and if you don't control their pain that much, they will not get out of bed. Our goal is to try to get the patient moving a bit, at least using the bathroom or walking a few steps. Not their usual activity level as it was before, but at least some level of activity is important. Bracing is, again, optional. Use it, don't use it. Some people use it, some people don't. But in general, bracing helps with kind of splints the spine. There are some patients whom you won't be able to brace if they are very obese or intolerant to the braces. But yes, acute management is pain, and then obviously initiate the anti-osteoporotic treatment.
So any role of early imaging, suppose the patient has garden variety of case, and if you go with, there is some what you call red flags, which we say, no, we'll get the MRI done today itself, and probably we don't prolong it for say 3 or 4 months, something like
So
that.
yeah, so there, if there is any suspicious of a secondary fracture, then you get an MRI done. So I mean, you would have a very low threshold for getting MRIs because MRIs are easy to obtain. So you don't really wait on that if you feel that there could be something else.
And in the morning, we tried to understand the kyphoplasty versus vertebroplasty and other things. So just wanted to revise what will be the probably the indications when we will probably suggest no, we go with kyphoplasty and other things.
So the common misconception, I know someone asked about the collapse of the vertebra and using vertebroplasty or kyphoplasty to prevent the collapse. Well, vertebroplasty and kyphoplasty are not meant to treat the X-ray, right? So you don't choose to do vertebroplasty or kyphoplasty at a certain time because the bone is going to collapse, 2 months later, because that it can never do. So it is a purely a pain management technique. It has nothing to do with how the fracture morphology will change or maintain or kyphosis prevention. It doesn't do that. It's only a pain management modality, which means your painkillers are not working, patient is bedridden status, you have tried everything you can to try to get the patient out of bed. It's been a month and the patient is still stuck in bed. It's going on, and you're going to get complications of a bedridden status. That's where the interventions come in. So the indication for doing cement augmentation is only pain, and obviously the fracture morphology should correspond. I mean, there should be no contraindication for doing it. Otherwise, you are putting in screws and other things in the back.
So my next, yes, sir.
Just one question, that one of the complications after kyphovertebroplasty is fracture of the vertebrae above and below.
Yeah.
Is there any way of predicting that? Can we know that these are the ones who may go? Or it is everybody?
It can happen to anybody because it can be just a progression of the primary disease, which is the osteoporosis. And as we have discussed, one fracture begets another fracture. So that can happen. And plus the cement augmentation actually changes the biomechanics in that area. So it makes that area more stiffer. So not only the adjacent body can fracture, but the same body can fracture. So you have like a D12 vertebra and you have put cement in it. Obviously, the whole vertebra get replaced with cement. There is a shell of bone around that cement, and then you have like a big ball bearing type hard cement inside, and the surrounding soft bone fractures around it. So that tends to happen if you do acute vertebroplasties a lot. Dr. Chadda just said that you shouldn't do acute vertebroplasties, but find many people doing vertebroplasties at 2 weeks or 3 weeks, and those are the ones where the surrounding bone also keeps fracturing.
So I want to come back to Dr. Balki, sir. So further management of this patient. Patient has fractured a normal BMD. So
there are no secondary causes. I give more importance to that fracture than the BMD.
Okay.
And this is an established osteoporotic fracture, and you need to treat. And since the patient is, and we have to discuss all the options with her, and that X-ray that Dr. Ragashi asked for is very vital, because this fracture is a severe fracture. If more than 40% fracture, then I wouldn't wait and give the best possible drug for an anabolic drug first, and then follow it up with something for maintenance later on.
Yeah. So you said that it's a normal sort of DEXA. And that's a really common situation. 25% of your DEXAs are not going to predict a fracture. In your patient, did the frac scoring, like retrospective frac scoring, could predict this?
So
or no?
nothing as such to predict this.
So frac scoring is also.
So this brings to my next question. So this is for Dr. Uday, sir. Sir, can we monitor? Say BMD is normal. Now the patient has a fracture. Now we start the anti-osteoporotic treatment, but the things how should we monitor this patient now? The thing is, BMD is normal. We are starting the anti-resorptive treatment, and the patient has fractured. So how will I monitor this patient?
Probably bone turnover markers might help, especially after starting treatment. If you're using an anti-resorptive, you should have a significant drop in your CTX.
That is the only way, probably.
That's the only way, because BMD cannot be monitored now.
Okay. Any comment from how can we monitor this kind of patients?
Monitoring means you are talking about from a medical point of view, monitoring, but
medical point of view,
patient also needs from the perspective of fracture healing point of view. So fracture, we will get repeat X-rays, 2 weeks, 3 weeks. And in the first 2 months, we will get a series of X-rays, which tells us how the morphology of that fracture is changing. So like sir showed that severity grading, it generally tends to change over time because the fracture is going to collapse and then settle at a particular, grade. And that leads to healing. Usually first month, patients should report approximately 30 to 40% of pain relief. That's the usual pattern of relief for after usual fracture. Patients who don't, at 1 month tend to be in a bedridden status. It's been 6 weeks, still bedridden status, fracture X-ray is changing a lot. Then we tend to get X-rays that are supine and standing. Because a supine X-ray and a standing X-ray tells us what gravity is doing to that fracture. And very often we will be able to diagnose avascular necrosis of the bone in such kind of X-rays. So in lying down, the fracture opens up and you see a common sign, a vacuum sign, and then in standing position it collapses. So you see a 20-30 change, kyphosis and supine to stand X-rays for the patient who is not responding. That's not failure of medical treatment. That's a mechanical problem. So pain response to treatment, if you're just judging by pain, it's two aspects. One is, patients refracturing again at different levels, or the same fracture not healing and going into non-union.
Thank you, sir. This brings to my third case. In third case, probably we have a patient with osteoporosis. We treated the patient with osteoporosis, and we're probably on the treatment. Patient has an atypical femur fracture. So just we go with the third case, and probably we have questions based on that.
Morning, sir and ma'am. I'm Dr. Sneha from Endocrinology Department. So my first for the case for today's discussion is a 35-year-old lady comes with complaints of fever, malar rash, frothy urine, and inflammatory joint pains. On evaluation, she's diagnosed with SLE and nephritis. She has been treated with steroids, MMF, and HCQ. She responds well and undergoes remission by around 9 years. And she is off steroids after 2009. And her first BMD in 2016, suggestive of AP spine T-score of -1.5, left hip of -2, and right hip of -2.2. So FRAC score is suggestive of a high risk. And she has been started with bisphosphonates, alendronate 70 mg per week. And it has been closely followed up. And a drug holiday has been given in the year of 2020. And she has been restarted again with bisphosphonates. A BMD later after this is suggestive of AP spine improvement up to 1.1. And left hip and right hip suggestive of -2.1 and 2. There is a definite improvement after bisphosphonates, but in 2023, she comes to us with right thigh pain since 10 days, which is non-traumatic, and she's not willing for any surgical intervention at present, and she has been managed conservatively with teriparatide for 6 months, and the X-ray is suggestive of a atypical fracture with transverse fracture line and thickened cortex. So post-treatment X-ray shows some healing, and BMD has improved with a T-score of -0.9. Left hip and right hip is -2.2 and -2.1. So the questions?
Okay, so in this case scenario, Probably we told the patient has a atypical fracture on the anti-resorptive treatment, and now probably she somehow avoided the surgeries, and now we arrived at the stage when we were asking the patient, should we restart the anti-resorptive treatment? So, sir, any specific, the patient has been mentally trauma because the medication has not worked for cross fracture. So any approach on this one?
So anyone who has an atypical fracture in the immediate scene, we will not think of anti-resorptives at all, because it can cause, although it's just on one side, there may be something on the other. Many times these are bilateral. And if you give anti-resorptives, it may increase it on the other side and lead to more and more problems on the side where the symptoms are. So at the first, it can be not at the immediate stages, because we have very few options left. There are studies and there are case reports and case series where it is first been treated with mainly bone forming agents initially, and then after a few years down the line, they have been treated. If there is no other option, then if the patient's fracture can be fixed, if the orthopedic surgeons think that this is something that can be fixed, where they put in the rods and other things bilaterally, if it has been stabilized and you don't have any other option, that's when anti-resorptive. So it's the last option. Usually you don't. I think Dr. Agashi wants to say something.
We always used to think that this is essentially a subtrochanteric level fracture. Fractures right up to the mid shaft or even lower are known. So one has to have a full length X-ray. That's the first and foremost thing. Secondly, whenever they get pain, then they need to be fixed. Incomplete fracture needs to be fixed, especially in presence of pain. And there are some scores which can be, have you included that? There's a score which would predict the chances of fracture. Complete fracture.
Okay.
Chances of complete fracture in an atypical fracture, in an incomplete fracture. Often I don't remember the score, but there is a score. Which can calculate.
Which can be calculated.
Yeah.
Okay.
Just one more comment. She was premenopausal when the first BMD was done. So there's a Z score. You're supposed to see that instead of the premenopausal.
Yes, ma'am. So we should have actually included that score. Other thing was patient was already on long-term osteoporotic treatment, probably, which added a lot of risk factors for fractures. So probably that was the one reason to start with. Yes, sir.
Just one comment. Can you go one slide back and show the DEXA scans? So one more. See, DEXA scans improvement is not based on T-scores. You look, the T-score is for that particular scan. It's not for comparison. If you have to compare, you have to compare the BMD, gram per centimeter square. And what you do is you calculate 6% reduction or improvement as far as the spine is concerned, and 3% for the hip. Anything above, below that, you can say it's either improved or gone down. And it takes about, at least in postmenopausal osteoporosis, 18 to 24 months before you can say that. And in PTH, since first the bone is laid and calcification occurs later, it is said that you need to do a DEXA scan 6 months later than you would normally do to get the real improvement with PTH. So you have to be very careful. And in most of the if you do it, and that's why we ask patients to do it at the same place. And that particular DEXA scanner should give you another box comparing what has happened every year. Never go by T-scores.
Okay, thank you, sir. So any comment from? Yeah, ma'am.
Denosumab also has a Denosumab has an even higher risk of osteonecrosis compared to bisphosphonates. What is the story as far as atypical fractures goes?
Okay, thank you, ma'am. So, Dr. Girish, sir, any comments on this part? Probably you want to comment monitoring of fracture in patients who already had a dynamic bone disease. Sir.
She said that does Denosumab cause more atypical fractures than
Denosumab, as we move around, I think it's emerging evidence that it increases the risk of not only osteonecrosis but even atypical. There is good data coming up.
Yes, okay, sir.
Just a few points. What Balki said is very true. We should carry on with the teriparatide to its normal conclusion, whether it's 18 months or 2 years. That will give us some window of time. if you look at the bone density scans, someone who's already been treated with hyaluronic acid, there is no urgency in going forward with more anti-resorptive drugs at this point in time. One other point that I suppose our orthopedic colleagues will agree is quite often AFFs are bilateral, and one should really be very carefully looking at the contralateral femur for signs of early loose zones. And I've had a couple of patients who've had prophylactic nailing because there was some concern about the other side. And that is not routinely followed, but we've also had patients who've had AFF fracture on one side, had surgical intervention, and then a few months later had the same problem on the other side. So, and for trainees, very important to ask about thigh pain. Whilst they're on any anti-resorptive, and Denosumab is actually a worse offender than zoledronic acid in terms of its propensity to cause these both ONJ and AFF.
Okay.
So
the recommended dose of Denosumab is for 10 years. In India, it's been there only for 9 years. We will finish 10 years next year, I think. That is what I remember. Somewhere Prolia was launched at 17. Yeah. So, but at the same time, you're talking that it also can cause atypical fractures. So basically, but in India, we have had Denosumab only for 8 to 9 years. So is there any report from India where they have reported post-Denosumab atypical fractures? We have a lot of reports of alendronate fractures. We are seeing that it is known. But is there any report, madam, in your experience, have you seen or anyone here has seen report?
I have seen post-Denosumab atypical fractures. I don't remember reading any published series or case report from India. I don't know.
One more query is that I was told in one of the meetings that zoledronic acid remains in the body. And supposing patient has taken zoledronic acid for 3-4 years, somewhere maybe 10-15 years back, and then recently he has been put on Denosumab. Is there a higher chance of atypical fractures theoretically?
Any anti-resorptive drug has the potential to cause atypical fractures. It depends on the duration of treatment and the potency of the drug. There is no clear linear relationship between a drug and what. And as you will recognize as orthopedic surgeons, atypical femoral fractures can be there without bisphosphonate therapy. So there are other reasons for having. In terms of Denosumab, there is no magic 10-year limit. People will say that you have to give the drug for as long as it is required, but you must also have a plan B if you can't give it. The reason being, both Denosumab and the anabolic drugs, there is very quick offset. Within 6 months, unless you have a plan B, unless you follow it up with an anti-resorptive drug, their efficacy will go away. And there are several case reports of Denosumab causing AFF. We published a series from the UK about 6 patients who had AFFs over a period of 10 years. So it does happen. It mainly happens in the oncology literature because they give much higher doses for much longer than we would in osteoporosis.
Yes, ma'am. Ma'am, also, yes, ma'am.
Maybe the next meeting also include medical ambulance dealing with metastasis.
Yeah, everybody talks about atypical fractures with all these medical issues. So I wanted to know, are there any risk factors? Can we predict that after 3 years, 5 years, 10 years, this is likely to cause or not likely to cause? And really, even I would like to know if there's any data in the Indian scenario regarding the incidences of atypical fractures with bisphosphonates and Denosumab. As you said, it's increasing. But do we have anything to talk about? This is for, sir. You have.
I have not seen. Yeah. Dr. Girish and Manuj also. We have 24 cases. in last 12 years. And unfortunately, many of them are 40% from rheumatology, 50% from oncology, and 10% I am the culprit. So I think there is a genetic polymorphism which Pete Trebling is working on, Asians. And other than that, I don't know what is this polymorphism. We can work on it. But other than that, there is some hip structural analysis which we see. We are looking at the association on the opposite hip. We are doing hip geometry and seeing hip axial length and CSMI and all that, whether they are correlating.
And also the thickness, cortical thickness.
Cortical.
Over a period of time.
HSA gives everything.
So we were talking about PPI use may be associated with probably may add on to
PPI
the
we are getting
risk
4 cases.
Yeah.
It's a risk factor. PPI we are getting into JBM 4 cases without bisphosphonate or Denosumab or Romosumab. Okay. Yes, ma'am.
Using a much higher dose. It's
Routine dose.
oncology and oncology days. So is it likely that it is dose related?
Definitely, there is a bone and osteoporosis, but with the 2 years of proton cancer, yeah.
So is it more common at a younger age or in females rather?
There was because the
But otherwise.
So one question which arises is, Girish, can we ask what? So, Dr. Thomas, I mean, hi, Thomas. So is there any case for serial monitoring of CTX while on long-term anti-resorptive therapy? And if you are seeing progressive reduction into very low levels to stop, forget about interval drug holiday after 4 years, but I'm saying even after 2nd year, if you're finding it too suppressed.
PGA. Don't give second dose of zoledronic acid if the CTX is less than 200. We have 48 cases. We have given single dose, 5-year follow-up. PGA has got more than 60 cases. Both of us are writing up because we have given only single dose, 4 years follow-up, no fractures, vertebral as well as non-vertebral. Number 2, the BMD increment has happened. It's continued to happen, single dose, which is following the pattern of Reed and Mark Bolan. They also published. But there is a group where that may decrease. So there is only a small group when it is suppressed, we are not. Sir, you want?
In response to your question, the primary question as a clinician is what are we aiming for with these drugs? Are we aiming for a suppression of bone turnover marker? Are we aiming for an increase in bone density? Or are we ultimately aiming for a reduction in fracture risk? Now, these are interrelated, but not the same. Trials use surrogate markers because they are easy to measure and easy to use for licensing purposes. The gold standard for any osteoporosis medication, whether it's working or not, is to fracture risk. Now, incidence of fractures in these trials, even big trials with thousands of patients, are relatively low. So in order to power it to have meaningful conclusions, you really have to have tens of thousands of patients. That is not possible. So the next best surrogate marker is increase in bone density. With zoledronic acid, the bone density, there is incremental change every year on year for up to 3 years, and then it starts plateauing out. And that is why the received wisdom is to give it up 3 infusions at yearly intervals. But as Professor Thomas was saying, we are now beginning to challenge that concept in terms of whether we are all locked into this annual thing. In practice, we are now increasing the intervals to 18 months to 2 years, using a bone turnover marker as an indicator, because it's a balance between the benefits as well as the risks. Now, the risks are very small in terms of ONJ 1 in 100,000, and AFib is similar. And and very elderly patients who are very frail, you can just give one and then forget about it. Someone who's in their 90s. So the whole concept of giving IV zoledronic acid, which is still the mainstay of treatment in osteoporosis treatment in the elderly, is being revisited.
Thank you, sir. So we move on to our final case.
Good morning. I'm Dr. Smriti from Rheumatology Department. I'll be talking about breaking through treatment failure. So this is the case of an elderly woman with long-standing rheumatoid arthritis who had undergone multiple corrective surgeries for the damage that had happened due to rheumatoid arthritis. She had also undergone bilateral hip replacement, which made monitoring her osteoporosis with DEXA scan a little difficult on the hip aspect. So she came to us in 1992 and she had history of long-standing rheumatoid arthritis and she was steroid dependent. In 2001, she was diagnosed with severe osteoporosis and she was started on alendronate once a week. From 2009 to 2011, she received teriparatide daily and then abandronate monthly for a year. 2015 to 2017, she received yearly zoledronic acid. In 2017, she underwent her left total hip replacement. In 1996, she had already undergone the right side replacement. So now in 2017, after the left side, she'd gotten both hip replacements and now monitoring it via the hip was difficult. From 2017 to 2026, that is approximately 9 years, she had received 6 monthly Denosumab. Last dose was in May 2026. In May 2026, she had a history of fall causing fragility fracture on the left proximal humerus on Denosumab. She was switched to Romosozumab in July. She received her first dose.
So my question is to Dr. Kavita Krishnan, ma'am. So do we label this as treatment failure of Denosumab or we have different perspective on this, ma'am?
Yeah, so by definition, failure of anti-osteoporotic medication is 2 or more fragility fractures when your compliance is ensured, and there's no secondary cause of osteoporosis. At the same time, if you have just one fragility fracture, along with that, you can have a DEXA to support or a bone turnover markers. But in this case, the challenge is that you have got bilateral hip replacement surgery, so DEXA hip cannot be done, and your DEXA spine is just minus 2.2. So you can have a surrogate site like radial lower 1/3 of the radius, the 33%, that can be used. The cortical area is good enough to give you some guideline. You can do the bone turnover markers. Having said that, I think 9 years of Denosumab, probably the patient, how old is the patient now? 60 with 34 years of rheumatoid arthritis. So probably it's an bone fragility state where nothing seems to work. So definitely the drugs are failing.
So ma'am, for this patient, apart from DEXA scan, probably we may monitor CTS markers.
Yeah, radius lower 1/3 DEXA, or you can do bone turnover markers to document. Yeah.
So how much importance do we give to forearm DEXA in such kind of patients probably? So do we really monitor them or probably they are just there?
As I said, they are surrogate markers. If you really want a minus 2.
And now probably the patient.
Yeah.
So any comments?
No. Forearm is used only if hip or spine cannot be used for some reason, and it is shown in some studies in hyperparathyroidism that it may be a very good site to look for.
Uday sir, any comment on monitoring? Same. So probably we didn't have.
Yes. Hi friends, I'm Dr. Parag Sancheti, Chairman Sancheti Group of Hospitals, and it's my proud privilege to invite you for the current Office Orthopedic course, Cook 2026. This will be held on 1st and 2nd August Grand Hyatt in Pune, and it is being spearheaded by our own Sancheti alumni, Dr. Kiran Shetty. This course promises to be
and the TBS negates the osteophytes and other things and still gives you a good idea of what is happening. So that's the whole importance of TBS.
And this will be attended by the galaxy of international and national faculty who will answer all your queries. There are also multiple pre-conference workshops.
The thing with TBS is that potentially they do say that you can potentially monitor the treatment. It is not approved. It depends on the version of TBS that you have. So the latest one that they have, they claim that is more accurate for monitoring of the TBS.
But specifically, if steroid-dependent patient, the TBS score, do they change differently? They do say more about quality of bone or they...
So one is in terms of a baseline. So in patients who have, for example, on glucocorticoids, the trabecular bone scores would tend to be on the lower side. But in terms of treatment monitoring, as of now, it is not approved. The newer version which has come, in that they claim that monitoring can be done for TBS, but it is not a recommendation.
Also, in the context of RA, I think forearm be even less relevant, you know. So, because you already see a very low.
So, ma'am, we always have black box warning for CVA events in this patient. Patient has long-standing RA probably, and she also has hypertension and dyslipidemia. So, how much should we think? Probably we have to switch to some different treatment. And before switching to Denosumab, we always consider CVA event. So, what will be the approach in this patient?
Yeah, so as per the ART study, the actual contraindication is if there's an acute coronary syndrome or a stroke in the past 1 year. Yeah, and hypertension, dyslipidemia are coexisting.
As if to tell the body that you've never taken it before and start fresh. The black box warning has been now changed to a cardiovascular event in the previous 12 months. Yeah, so it's not forever. So if there is an infarct 10 years ago or 6 years ago, there's no problem.
But if you use teriparatide immediately after denosumab, there will be increased bone turnover and there will be rapid decline in the bone density and chances of fracture were very high in first 6 months to 12 months. So ideally after denosumab, we should never use teriparatide.
Transition. Yeah, transition.
I totally agree with, because there are 3 studies which showed after denosumab there is a decrement in bone. Yeah, all said 6 months. Then it starts stabilizing. Yes.
So now, what is the age of the patient?
60.
So she has at least 25 years of life left, or at least 20. Now, what will you do after your Denosumab is over? After 1 year, what is the recommendation to be done? Is my question.
I think what they're doing is after 2 months of stopping denosumab, the last dose you have given romosozumab, this transition time is fine. The next dose of denosumab you'll skip, and then you will give this for 12 months, right? So after that, romosozumab.
Yeah. Have to take a call back again for 2 years.
No, on July 27, what will you do?
Yeah, so I think in July 27.
You know what I will comment.
New drug.
Ivizol, yeah, that's what. So
He's in such a hurry. After giving a new drug, we should allow it to work for a year or two and then take up. I mean, obviously the fracture risk is taken care of to the man if we give it a
So you're given 9 years of denosumab. So there is a paper that was released last year where they quantified the duration of denosumab and when you can stop safely. Now, in terms of if somebody's on 9 years, even if you give Ivizol at the end of your romosozumab, you're going to get bone loss. There's nothing you can do to prevent it. It's only the rate of decline that will come less. So even if you give it at 12 at the end of Romo, and you repeat it after 6 months also, which is the recommendation after monitoring the bone markers, there will be a decline in bone density that will occur.
Even if we give zoledronic after before 6 months of completion of denosumab, we give zoledronic acid, there will be definitely a loss in bone.
It depends upon how long you have used denosumab.
I'm Dr. Parag.
So if you have used for 9 years, in spite of giving Zol, you will get a decline. But that may not translate to fracture risk.
2026.
It may reduce the fracture risk, but you
This will be
get
held
bone
on
loss.
1st and 2nd August at the Grand Hyatt in Pune. And
One thing which I wanted to clarify is that we give teriparatide when there is a fragility fracture, major fragility for 2 years. then we maintain them on either denosumab or alendronate or whatever zoledronic acid, that is anti-resorptive. Now all this has happened here, and after rosuzumab 1 year course is over, now we have exhausted everything. So shall we, and you are saying that you should give it some time to act. So how much time? Means 1 more year patient can be without any drugs, only calcium, vitamin D?
Held at St. Hospital.
After rosuzumab, exactly. Now yes, she is finished with everything. What should we
There are
do?
few seats left for the main conference.
Again start
and also
denosumab.
few seats left for the pre-conference workshop. I promise you, you will not regret. All the best to the team, Cook 2026 and to Kiran Shetty as well.
As Thomas Paul said, and even there are studies from PGI where you're titrating the dose. See, 6 monthly is the dictum. But I think it will evolve. Okay, you titrate it based on BTMs, whether your CTX is suppressed. If it's suppressed, you can still transition, wait for some time, and probably then dose it accordingly.
Hi friends, I'm Dr. Parag Sancheti, Chairman Sancheti Group of Hospitals, and it's my proud.
So it depends. If you're using an anti-resorptive, it's CTX. If you're using an anabolic, it's P1NP. Either of the two, depending upon what you're planning to give.
But rosuzumab has both.
Yeah. So obviously you're going to complete the course irrespective of.
So after 1 year, we just do these tests.
Yeah.
And depending on the test.
Subsequently, you're going to anyways follow it up with an anti-resorptive, not an anabolic. So your CTX is what you're going to look at. 6 monthly.
Okay, I think.
So I hate to break
I
this
think it's-
discussion, but
That's the question. Actually, we close the session now.
No, aside, this lady is a rheumatoid who's been following for more than 25 years. She's had 4 or 5 joint replacement. One joint is infected, and she's a fantastic artist. She does metal work and with deformed joints, phenomenal artist. So she's been for a very, very long time.
thank you, Dr. Sandeep. Thank you, everyone in the crowd, for making this one of the best panels. And can we break for five minutes for a short coffee and water break, and come back so that we can have lunch early?
The CV is like that. Quite late. Only CV. I mailed the presentation. Oh. Yeah. So the latest one I sent is the final.
Finally.
So this was a scan. This was of an orthopedic's wife, the hospital where I work, and they came with this report. But you can see here that the spine has been started very up. You can't see the pelvic brim. Also, you can see that the intervertebral lines are not in the intervertebral spaces. So this is an incorrect scan. And the hip, here you can see that the femoral leg box has been compressed. They're tampered with. They have compressed it to fit it into the femoral leg. Again, that is incorrect. And so this is a wrong scan. Similarly, you can see that the femoral leg box has been tampered with. And here you can see that the bone edge is not outlining the bone. So when we look at a scan, we must look, for example, at the spine. It should be acquired correctly. So should include the pelvic brim up to the T12 vertebra. It should be straight, centered, equidistant on both sides. The yellow margin you should look at, this is the bone edge. And it should be correctly labeled with these lines in the intervertebral spaces. Similarly, at the hip, it should include acetabulum, greater trochanter, lesser trochanter, and part of the femoral shaft should be straight with the femoral leg box, outlining the femoral neck and ideally nothing else. And you should look at the yellow margin, that's the bone edge. So this was regarding some common mistakes that occur in the DEXA scan. And these are not from any other place. This is from Mumbai, from top centers, top diagnostics and hospitals. Okay. But sometimes bone density is not enough. We get, in fact, so although osteoporotic patients are more at risk of fractures, there are more number of fractures occurring in osteopenic and normal bone density. So there's something beyond bone density. Okay. So to try and capture more fractures, there are some softwares which are used now. For example, the Trabecular bone score. It is to assess the microarchitecture of the bone. And it uses the grayscale analysis software. So better the quality of the bone, the microarchitecture, you get a higher score. And poor quality, you get a lower score. So there's been a lot of studies with regarding to TBS. It is used in osteopenic patients for secondary osteoporosis. It is not affected by degeneration and osteoarthritis. It's likely to be helpful where the FRAC score is at the close to the intervention threshold. And if you have, it may help you to decide anabolic versus anti-resorptive treatment. So we don't use TBS values alone by itself. We put it into FRACs. So in FRACs, you'll have this button here, adjust with TBS, and you put the TBS values in, and you get a score. So as per a large study, over 30,000 patients, they found that up to 29% of patients were reclassified from osteopenia to osteoporosis, and 5% were reclassified from osteoporosis to osteopenia. At my own clinic center, over 1,500 patients, it reclassified 2.2% patients. So not much. So 5 patients moved from osteopenia to osteoporosis, and 6 moved from osteoporosis to osteopenia. The other thing was that you get patients who fracture even if the bone density is not too bad. So TBS, in those patients who are osteopenic and normal bone density, I had around 38 patients who fractured in normal and osteopenia osteopenia, and out of which 40% had a lower TBS value. The other concept is that there are certain treatments that improve the microarchitecture, so thus would improve the trabecular bone scores. And so based on the TBS, one may potentially decide what treatment will work best. For example, so anabolics improve microarchitecture while bisphosphonates are neutral. So let's see how this has helped our patients. This is a 53-year-old lupus patient on prednisolone. She is postmenopausal. She has a T-score of -3. And we do VFAs, no vertebral fracture. Her microarchitecture, TBS values are very low. And we treated this patient with teriparatide. So every software has a limitation. The limitation is the abdominal thickness associated with, and that's associated with decreased TBS. So increased abdominal fat can cause a false decrease in the trabecular bone scores. And now this is especially important in diabetic patients where you may get false low TBS values. Also, in patients who have extreme BMIs, it is not accurate. Then VFAs, we have spoken a lot about vertebral fractures, the indications in women above 70 and men above 80. I think we should do it much earlier. Then patients who have height loss, who have self-reported vertebral fractures, patients on steroids. And a lot of these patients have silent vertebral fractures. It has good sensitivity, radiation is minimal. And vertebral fractures are common even if the bone density is not too bad. And as Dr. Balki sir said, that one fracture increases the risk of other fractures, not only the spine, but at other areas, and it affects mortality, morbidity. It will change your evaluation and management. So this is a patient who had come to me. Scan was done outside, minus 2.7. And I found something a little bit odd on the scan, I'll tell you. So I got it repeated, okay? And she had a vertebral fracture. What I saw here was there was an increased little bit of sclerosis at this thing. I just suspected that she may have a vertebral fracture, and she had one. And she had poor trabecular bone scores, and we treated this patient with anabolic agent, teriparatide. This is a 69-year-old female, ILD on corticosteroids, bone density, osteopenia, not too bad, but she had a vertebral fracture, and she did not know about it. And she had low trabecular bone scores. This is for my center. Out of 1,500 patients, we have 94 patients who had vertebral fractures. And you can see 21% were in osteopenic, and 1% had normal bone density. So we will miss out a lot of patients. We'll miss out treating appropriately if we are only relying on bone density. And vertebral fractures increase with age. And in our rheumatological patients, it can occur in younger age groups as well. This is elderly lady who had come with these multiple vertebral fractures, but this fracture, you can see there's a lot of sclerosis. She was evaluated and she had myeloma. The other helpful thing is that you can see that, this is a patient of dish. This is just some degeneration, syndesmophytes. So when I look at VFAs, it also tells me whether the spine is valid or not. Whether there are a lot of osteophytes and all, I feel that, okay, the spine is not giving accurate results, then you take the forearm into consideration. Or in certain situations, then do QCT. You can see this is ankylosing spondylitis with syndesmophytes. There's a newer software called the 3D Shaper by a team in Spain. So basically, it converts the DEXA 2D image into a 3D image, and they divide the hip into cortical and trabecular bone. So it's a normal scan. It has been used in the arch and the frame study. And this is how the report looks. This is cortical. This is a cortical porosity. Yeah, you can see trabecular porosity, the inside part. Here, both the hip thing. So their theory is that every treatment works differently. You have some treatments working on the cortical part, some working on the trabecular part, some working on both. And depending upon what reading it is, you can give treatment. So let's see the 69-year-old female, spine minus 1.9, TBS normal, femoral neck is minus 2.8, no vertebral fracture, has cortical porosity, and the zoledronate works at the cortical part. So she was treated with IV zoledronate. The other very useful tool is the body composition. Today, just assessing the bone part is not enough. I think so. Looking for sarcopenia is extremely important. So because as we age, we not only lose bone, but we also lose muscle. And this is associated with increased morbidity, mortality, falls, etc. So the body composition helps us to assess the lean mass, fat mass, which can divide the visceral fat and the total fat. So the relevance is for sarcopenia, we look at the appendicular lean mass index, which is the muscle mass of the arms and the legs. It detects visceral obesity. And in today's days of Mounjaro and Ozempic, what we are losing, we're losing muscle, fat. It can track that. So sarcopenia is assessing muscle mass by DEXA. But not only that, but looking for muscle strength by using the hand grip, and then impaired physical performance. So this is the hand dynamometer that we use. So let's look at this patient. This patient BMI is normal, but has a high total body fat, has a high visceral fat. Appendicular lean mass index is very low. The cutoff for men is 5.7. Grip strength is very low, 19.5. So this patient has sarcopenia. We did the bone density, osteopenia here at the hip and the spine, but the FRAX scores were low. Hip is 4%. So this patient has osteosarcopenia. When we quantify the muscles, the patient realizes that actually the bone muscles are weak and they can act on it, and it really changes their perspective and it makes a big difference rather than just giving them a generalized recommendation that you should do strength training. When we quantify and we show them, it changes their perspective. Let's look at this patient, a 70-year-old female Parkinson's patient. Mother had history of hip fracture. She had 2 falls. Her T-scores are very low. TBS is normal. Hip is -2.4. No vertebral fracture. She had trabecular porosity. We gave this patient teriparatide because she was high risk of fractures because of recurrent falls, and low grip strength, low appendicular lean mass index. So she had osteosarcopenia. This is a lady of psoriatic arthritis. So she was on secukinumab. She was obese. She had OSA, and she was started on tirzepatide, and she lost 11 kg, and she was lost to follow-up. In between, for a year, she was traveling, and then she came back. She was very happy with the weight loss, but we had done a baseline and a repeat. So out of the 11 kgs, she lost more than 50% was muscle. She was not taking proteins. She was not doing strength training. She was a 60-year-old female. So she lost muscle, and her grip strength reduced from 16 to 12 kgs. So body composition we have to do it in a certain way. Some precautions have to be done. Fasting state, limited water, avoid gymming, strength training, because these are parameters that can change the values. So it has to be a control thing, not like a health checkup where patients are doing and there's no proper thing. This is a patient, a body composition done from a very renowned center, but you can see that the hands are on the chest. They're supposed to be on the side, and this is absolutely incorrect. So to conclude, we must know how to interpret DEXA, and we should do it in a stepwise way. Tools especially like VFA and to a certain extent TBS can be helpful to pick up more osteoporosis and may potentially help us to guide treatment. Body composition using to diagnose sarcopenia, I think, is very, very important. And but in the end, we must treat the patient in front of us, look at the clinical risk factors, and manage the patient. Thank you so much.
Dr. Puneet, I just wanted to know whether there is any tool to compare lunar and hologic BMD.
Okay. So it has to be a cross calibration. Okay. The database at hologic is different, and the G is different. So if you see the hologic machines will have lower T-scores of around 0.5 at the spine compared to the G ones. So that's what I have noticed. So there has to be, if you're having, if there's a cross calibration done, then you can compare. If there's no cross calibration, you cannot compare. Even if you have G and G, there has to be a cross calibration between the machines.
That's why serial monitoring on same machine is more important rather than
correct
doing it at different machines. Yeah,
absolutely. Yes.
Yeah. Any questions? Yes, sir.
You mentioned that for comparison, you should do BMD and rather than T-score. However, T-score is from the same base. So why is there a difference? And the T is also from the same base, same peak bone mass. So
yes, sir. So the T-scores may change with the age. So I think that is why it will not used for comparison.
yes. Fair enough, but suppose a T-score has changed from one level to another. How do we explain to the patient that why does it change?
Again, the extension of same, if your T-score has improved over a period of time, so does it indicate improvement in the bone density as well?
So the thing is that we're looking at bone density, BMDs for comparison. From stopping treatment, T-scores can be used. For example, bisphosphonates, you may consider bisphosphonate holiday when it is above -2.5. For denosumab, you may consider stopping when it's above -2, for example. So maybe it can help to decide your treat to target. But for monitoring purposes, it's not recommended. Yes, ma'am. So
Still, you can't compare the T-scores.
no, ma'am. T-scores are not to be compared. T-scores will change with the age. We are looking at the bone density.
It's a derived terms of improvement. 3%, 7%, 10%. That T-score is not there. The BMD value is very important because see, when you are comparing these scores, the reference population of every 5 years change. Like we are comparing after 5 years, the reference population is also changing. Like especially with the reference population can change if you are like when you are updating, and the T-score is a derived value, whereas the actual BMD is absolute value. It's not ordered, but we can show the patient like -2, it has become -1.5. There is a less minus, but when we are doing as that percentage change, it is the absolute value.
Again, while evaluating bone BMD also, you have seen that he has shown many images where slight change in the position might alter the BMD also. So the DEXA scan which was done 4 years back and now done now, you might have some alteration in the position and which might change the bone density BMD.
Every 6 months.
Yes.
But it's a strict rule. Because I've seen, I don't want to mention which center and all that, CV, like, the BMD changes with the same morphology. So the CV is very important. Correct. CV, you all agree that
Yes,
CV is very important, sir.
Also, like when I'm doing comparison, if the scan is from outside, I keep the scan side by side. If it's my own center, then I look at the area. I look at side by side and look at the area. The area should not be significantly different in terms of the value.
Coefficient of variation.
In short, you have to pay your technician very well.
You said there was a difference. When you said that there was an error because it wasn't that correctly.
Correct. Yes, ma'am.
So what is the volume of that error, and does it make a treatment difference also? We would like to know.
So
what is the volume of that error?
So the volume of error depends upon how much change in the position there has been in terms of from the hip. Yes.
Ma'am, the DEXA technician has to be trained, and they have to do the scan in the right way, or else this will happen regularly.
So
that is most important.
So, ma'am, you're talking about the LSE value of my center that way. So it's so I have derived my error value. So when I'm comparing, if it is within that, bone density is stable. If it is beyond that, then it is either increase or decrease depending upon the change.
And it's not available on the health.
No, that is a manufacturer related thing, but that is not correct. We are supposed to derive our own CV and LSC. We don't take the manufacturer error value. We have to derive our own value.
So thank you, Dr. Mashru, for an excellent talk, and I'd like to thank the chairpersons. We have a very interesting panel. Some parts of it have been covered, but there are some parts we would still like to touch upon with our expert faculty here. And for this panel, I would like to call upon Dr. Sneha Kothari, ma'am, and Dr. Puneet to please be on stage. So Dr. Sneha Kothari, as we met her yesterday as well, she's a consultant endocrinologist at Global Hospital, and she has many publications and is a faculty at WeCare. And Dr. Mashru, as we all know, I would request them to kindly introduce the panelists for this panel.
Dr. Pramod Gandhi was here, right? Welcome, sir, for the last panel discussion of this wonderful academic feast, sir. Dr. Pramod Gandhi is consultant endocrinologist in Nagpur and he's vice president of My Endocrine Society. I call upon Dr. Thomas Paul also, sir, as an excellent work with. He's consultant at CMC Vellore Hospital. Come, sir. And Dr. Rohini Samant, she's consultant endocrinologist in rheumatology at Hinduja Hospital since many years. Yeah, Dr. Devish.
Good afternoon, everyone. I am Dr. Devish, endocrinology resident at Hinduja Hospital. So my case is a 65-year-old postmenopausal woman who was diagnosed with osteoporosis, and menopause had occurred at the age of 45 years in this patient. She had no prior history of any fragility fractures, and her mother had suffered a hip fracture in their late 70s. Patient is also a type 2 diabetic since 12 years on metformin plus sitagliptin combination with an HbA1c of around 7.2. There are no risk factors for secondary osteoporosis like steroid exposure, smoking. So at diagnosis, her baseline BMD at lumbar spine was 0.785 with a T-score of minus 2.5. And at hip, it was a T-score of minus 2.2. And the relevant investigations before starting the treatment were this, with a sufficient vitamin D level, calcium, phosphorus, and ALP whereas written. So patient, patient was initiated on Denosumab, 60 milligram for every 6 months. Patient received the treatment for around 7 years, and patient was compliant. So these are the BMD done at baseline at year 3 and year 7.
So here if we see the BMD, initially there was increase in the BMD and they have compared T-score also, but right now we learned that it is BMD that we should be comparing and not the T-score. So if you see here, initially there was gain and later on it kind of plateaued. So Pramod Gandhi sir, if there is a plateau, does it mean there is a treatment failure? Should we be looking at secondary causes of osteoporosis or plateau is known after few years?
See, it's almost 7 years of treatment of denosumab in a postmenopausal woman who is diabetic, who has family history of fracture to her mother. So probably I will say that it's a plateau effect of the denosumab. I won't say that this is a treatment failure. Unless patient has repeated fractures, multiple fractures, we can't say that this is a treatment failure. Probably it's a plateau effect which we see here in this patient.
Okay, so we learn what is treatment. Yeah, you want to ask ma'am something?
I have a question. We will give it, the plateaus will give it the next 2 to 3 years, right? We'll give it or you could stop. Let's say if it has plateaued, there are no worsening, there are plateaus. So in such a situation, how are you going to follow up in the bed, right? Saying she's already 72 years old, it's plateaued. The next step.
The indications of continuing denosumab are if there is increase in the bone mineral density in this patient, which is not significant right now, which is plateaued. If patient has recurrent fracture or very high fracture risk, probably those are the indications where we might continue denosumab. Otherwise, this patient should be shifted on anti-resorptive therapy like bisphosphonates.
I didn't get your question. Was madam?
Patient has already received treatment for 7 years.
True.
And there is some improvement in the BMD and then it has plateaued for the past 4 years. Now, as per the guidelines, we can give denosumab probably for another 2 to 3 years. If we make it. So should you continue denosumab? Should we change? Or should we take a break and reassess the patient after a year or so?
Break. You want to stop it? We won't.
So should we continue with denosumab?
Yes, because
should we change to
no, when they respond, the BMD, when we see 3 types of response when we give any treatment. One is BMD increment, BMD plateau or BMD decrement. Here it is the plateau. So unless, see, this is one parameter. The second parameter is fracture, fragility fracture. So whether you have done any VFA at some point of time?
The VFAs have not been done, but there is no history of any fragility fracture.
Okay, so no. That is not equal. VFA may, like, morning also. Yeah, so that is the thing. So when it's plateau, it doesn't mean that it is not responding. We can definitely shouldn't discontinue. We should continue. That's what this thing is, especially with the denosumab. The moment you stop, you are going to see the decrement.
So my question is,
please understand that in a normal person with age, there is going to be a decrease in BMD. If there is no decrease in BMD, then something good has happened. It may not increase, but the fact that it is maintained is also good.
Yeah.
What
do you want to keep?
maintenance
So, stable we won't.
So everyone said ki we should continue treatment in this patient, but patient is saying, see doctor, 7 years have taken. I don't want to take it further because we all know osteoporosis comes with sign, doesn't come with symptom. Why should I take when I have no aches and pains? So she said, I want to stop. So we decided to discontinue the treatment. So next question, we all know when we stop denosumab, especially if it has been used for more than 2.5 years, there is always a chance of rebound worsening or rebound vertebral fracture in this group of patients. As you see in this patient, at 7 years, when patient was on denosumab, CTX, which is a bone resorption marker, was 80 and it went up to 850. So next question to Dr. Thomas Paul sir is, sir, how do we go about when we decide to discontinue denosumab treatment in such patients who have received it for long term?
See, this is the 7th value of writing, no? This is how many days after the denosumab you have done this.
So on denosumab.
No. On denosumab means what? Like today, patient has received denosumab. This was done after how many months?
So this
4 months. 4 months is a very good response. Very good response. It's it start. Yeah, no, I'm just saying 9 to 12 months. It is this is what you expect in many patients.
Yes.
So you have to make a definitive choice and you have to instruct the patient whether she wants that or you have to change over to other anti-resorptive.
So how do we go about changing? If patient is saying, I don't want to continue, do we use bone turnover markers or BMD? Do we do it at 3 or 6 months and then decide whether patient needs zoledronic acid as a maintenance after stopping denosumab?
So here already it has the CTX is very high. Say in my lab, anything above 400, 500, I know that the bone is burning. So I have to quieten the bone. So I will, in my setting, I will give zoledronic acid.
So that would be 3 months, 6 months down the line after the last denosumab dose or
okay. So her question is when you give, now in this setting, you give the zoledronic acid now. But patient, when you see, what in Indian setting is if patient has received more than 6 doses of denosumab, if you give 1 dose of zoledronic acid and you do the BTM after 6 months of that dose, the BTMs may not be suppressed. Then we have to hit with not that 1 year business. After denosumab, this osteoclastic pumping is so much, you may have to repeat dose of zoledronic acid, not at 1 year, you have to 6 months in cases, many cases like that.
So
especially the more the duration. There are 2 studies, they have kept the 6 doses of denosumab, then you have to pump.
Okay. And suppose if if we have to summarize, after 6 months, 1 zoledronate should be compulsory given is what I understand, sir. And then we have to repeat based on the CTX markers, the zoledronate dose again.
So I will do CTX. That is what we are following in our, if transition from denosumab to zoledronic acid, if the CTS is suppressed, what I mean by suppressed in my lab is 250 or less. If it is, then I don't repeat I don't give the zoledronic. But somebody has got 400, 500, then I will repeat one zoledronic acid. It's a evidence based also.
And suppose if this patient had treatment failure, developed fragility fractures, post denosumab, what do we do? If patient has got vertebral fracture now, is there any role of anabolic agent like teriparatide or romosozumab?
So I think that came out in the previous discussion that after denosumab failure, romosozumab is probably the preferred agent. But practically, we do have difficulties sometimes in making the patient take it because of financial constraints. Now, because it has a dual action both on anabolic as well as resorption, so I think the rebound effect does not happen, and therefore romosozumab is the preferred option if there is a true failure of denosumab treatment. But practically, sometimes we have to use teriparatide because of cost issues. And just to complete, that one of the things that has been suggested in this situation is to start teriparatide within 6 months of the dose of denosumab, so as to have some amount of resorptive effect and anti-resorptive effect remains when you start the teriparatide. So if you are forced to use that, then you may use it within 6 months or before the next dose is due.
Okay.
I think one more carryover message is on any treatment, a patient can fracture fragility. So a single fragility fracture is not equal to failure.
Failure.
You can still continue with your treatment. And if there is a second fracture, then you need to use it. And any anabolic therapy after out of denosumab or osteoporotic acid, in the next 3, 4, 6 months, you need to be extra careful because you don't really expect it.
So I think the definition of failure, even Kavita mentioned, is, yeah, as you said, 2 fractures at least, and
the decline
maybe
in
a
BMD.
decline in BMD as well as the markers increasing. So
when you shift from the anti-resorptive therapy to anabolic therapy, obviously teriparatide is not the first choice. Romosozumab can be given, but there is some data that in those patients who are at very high risk of developing fragility fractures or more than 2 fractures, in such patients probably you can give the combination denosumab along with romosozumab initially, and then gradual shift to romosozumab. That there is some data, sir.
I call upon Dr. Puneet Mashru for the second case discussion.
Good afternoon. I'm Dr. Keyur Desai, DNB resident in rheumatology at Hinduja Hospital. And this case is of a 60-year lady. She was suffering from lupus. So she had features of RA and SLE both. So erosive arthritis and leukopenia with oral ulcers, dsDNA positivity. So she was diagnosed as lupus in 2001. And she was on DMARDs and long-term steroids. The average prednisolone dose was 2.5 to 5 mg per day. And she was also on calcium and D3 supplementation. Her past history included disseminated tuberculosis in 2005, which was treated. And her menopause was at 48 years. And she had a right proximal humerus fracture around 4 years back, 2022. So she had received 3 injections of zoledronic acid from 2012 to 2014. And after that, she was not compliant to zoledronic acid. She was lost to follow-up for many years in between. And after her proximal humerus fracture, she took 2 more injections of zoledronic acid. So total 5 injections of zoledronate. And she came to us in February 2024 when her DEXA scan showed T-score of minus 3.6 at the AP spine and minus 3.3 at the left femur neck and minus 3.4 at the right femur neck. So she was started on Denosumab in July 2024. So she had received 4 injections of Denosumab till December 2025, and she was due for her next injection in June this year.
Failure. It's just one fracture.
Yes.
But practically, I don't know how we would consider this. I mean, we do not have sufficient data to, call her as per the definition of treatment failure.
And what investigation, ma'am, will you do for this patient? Any further evaluation that you would like to do?
So basically, when a patient who has a connective tissue disease or rheumatoid gets a fracture, so apart from the mineral density, we have to look at disease activity. And I think we don't have data here about her disease activity. So that also can impact the BMD. And so we need to assess her disease activity. We need to see whether she had any renal disease, or a CKD. We don't have those values, which can also impact the bone mineral density. We need to look at her physical activity, which also, and obviously she's also on steroids. So these are additional factors, and some of them may be correctable or treatable, but we need to look at these factors before we look at only Denosumab as the,
Right. So in this acute setting, any role of CTX of the bone markers, bone turnover markers? The CTX and P1 and P in monitoring the patient?
So, I mean, one of the things to label her as a failure of Denosumab might be the CTX values to see whether, they are rising or they are high, which might say that there is a failure of Denosumab. The other thing which may be stressed is that the dose of Denosumab has to be at 6 months, even a little variation, but here, of course, she had not completed 6 months. But say if it's 7 or 8 months, sometimes we have a rapid rise in these values. So the values might help us in deciding about treatment failure.
Right. Thomas Paul, sir, in such a situation, what treatment would you prefer? She had a fracture. Any anabolic agent that you want to give, or we continue Denosumab?
See, adding to Madam's this thing, we do see in Indian setting 2 types of response with the Denosumab when you do a bone turnover markers. First set you give and you repeat the bone turnover after 3 or 4 months or just before the previous dose. Like tomorrow is the second dose. At that time, the PTM will be still suppressed. That is one group. The next group is CTX is very high. So you have to repeat it. So we are not sure, but though there is some studies from PGI, they say you can dose it according to BTM, but we need a hard data. So coming to the treatment, first of all, I'm not sure whether it's a treatment failure. I'm not sure. So I don't know whether I will get the expert opinion. See, I'm not sure because 7 doses or 8 doses. How many doses patient received in Denosumab?
4.
4 doses. I'm not sure whether it still is a treatment failure. I may not jump and give. I don't know. So the answer is I don't know.
So difficult.
If I am in the position, I will not go into anabolic. I may continue. Sir, honestly, I don't know the answer.
Anybody wants to comment on this? Because this is a difficult situation.
In fact, addition of anabolic agent, any of these anabolic agents will only increase the worsening of the bone density and increase the fracture risk in such patients initially for at least for 6 months. Teriparatide or Denosumab, because it will increase only CTX will not be suppressed with any of these anabolic agents.
Right.
So only continuation of Denosumab will be better option.
Okay. So following the completion of anabolic agent, which long-term treatment would you plan? So now this patient started on teriparatide. Do we continue Denosumab? Go back to the IV Zolintonate? or we give combination treatment, teriparatide with denosumab, then
I would consider using bisphosphonates after 2 years of, after 1 year of romosozumab treatment.
sure.
Mhm.
Our data 420 or something, teriparatide, the majority preferred zoldonic acid. And we found that their 2-year follow-up, it was good. And maybe 80%, 20% on denosumab. So they are also okay. So with relation to the fractures, I think that's your choice, whether zoldonic acid or denosumab. You can also comment, Dr. Punit, what is your thought process? You are also an expert.
So she's a bit young patient, so I'll prefer Zol to mentor on Zol long term, chill and then pan out. But it's a difficult situation to be in.
Good afternoon. I'm Dr. Minas, a first-year resident in endocrinology. This is a case of a 67-year-old postmenopausal female who was referred by the dentist for fitness for a tooth extraction. She has a past medical history of osteoporosis, diabetes, hypertension, and a history of breast cancer 15 years ago, for which she is on letrozole. She is not a smoker. She does not have a history of rheumatological disease or receiving any exogenous glucocorticoids. She was first evaluated for osteoporosis at the age of 65 by BMD DEXA and was offered treatment options, oral or parenteral bisphosphonates or denosumab. And she chose to start with parenteral bisphosphonate, IV zoledronate. She received 1 dose in 2025 and 1 dose in 2024 and 1 dose in 2025. These were her BMD and T scores. At present, she has dental issues for which a tooth extraction has been planned. The dentist has referred for preoperative fitness for the same.
So Dr. Thomas Paul says, so how do we define osteonecrosis of jaw and what are the risk factors?
See, what was the indication for initiating bisphosphonate?
You see, she was started, but her BMD T score was minus 2.2.
Just any other additional result? She was in osteopenic range and test.
CA breast on.
CA breast on. Okay.
Let's
Sure,
talk
there is a
about
risk factor there. So the risk factors will be like, see, it's now it's getting more and more refined entity. There is people who are received bisphosphonate or radiation therapy or infection or like, smoking. You clearly said it doesn't smoke, diabetes, and what is going to precipitate it is any procedure which is getting into the oral hygiene, poor oral hygiene, which is getting into that bone that is going to precipitate. So these are the known risk factors.
The only thing is when we start patients on anti-resorptives, as a routine, before we start, do we ask them to meet their dentist and complete their dental work? Because majority of these patients are elderly, they may have some cavity, they may need dental extraction. So as a routine, do we send them to the dentist before starting so that they can finish the...
So in CMC, what we do is we do the examination. Anything particular, we refer or we'll ask the patient before starting. Otherwise, getting dental appointment is 6 weeks. So the patient will disappear. So, so we check after if anything overt or that's the thing. Otherwise, I don't know. I'll ask other experts also.
It's like, what do we do usually?
But at least those patients who has high risk like malignancy along with you are starting IV bisphosphonates, probably in such patients it's better to take opinion.
Okay. And ma'am, compared to oral bisphosphonate, IV bisphosphonate or denosumab, any agent is more prone, and does duration of treatment affect the risk for ONJ?
Yeah. I think yes, IV has a higher risk as well as the duration of treatment. So with oral, I think even up to 3 years, there's no major impact. But with IV, every year there is an increasing risk of ONJ, and particularly in the context of malignancy. So when it's being treated, because the dose also is higher in that context.
So if this patient has to undergo dental extraction, will you certify fitness? What will you tell him? When should he undergo dental extraction? Suppose patient has received injection in December, last zoledronate, and has come for follow-up in March. So is there any role of drug holiday, or how do we go about it? If patient is on 6-monthly denosumab, some articles say that just before the next dose of denosumab, you should go ahead and do the extraction. Do we follow that on a routine thing?
Practically, I cannot answer this question because I haven't done this, but I think the data says that there is some study which has shown that a 3-month holiday for certain of the bisphosphonates, the oral ones, and a 1-year holiday for zoledronic acid. That is what the literature says. I practically do not have any experience with this.
Dr. Kaushik wants to answer. Yes. In reality, having a short break, is good for the doctor, but it doesn't really make any difference to the patient because these drugs are so bone avid. Zoledronic acid will stay there for 10 years.
10 years.
We tend to do scrupulous dental checkups before starting them on this, so that if they need any dental procedure, we try and get it done before starting it. Once they're on it, to just supplement what Dr. Rohini said, risedronate theoretically has some advantages in these patients. They are relatively less bone avid than perhaps zoledronic acid. The duration of treatment matters. With Zol, we are increasingly giving it at longer intervals, and you can give a drug pause. So overall, the risks of ONJ are probably a bit less because with denosumab, you're locked into practically lifelong use. So although they are short acting, but you are going to give it, the exposure is for much longer.
Yeah.
And in our center, the ones that we do have are 5 or 6 of these patients. One is for oral cancer.
Okay. So for denosumab, that is what the recommendation is. Before the next dose, maybe you can undergo the dental treatment is what they have tried to say. Yeah.
For example, surgery, like patients are on Denosumab, right at the end of the 6 months or when their drug levels have dropped. The thinking being that their infection risk is at their lowest.
And suppose if this patient is at high risk of fracture and we need to stop denosumab for whatever reason, would you put this patient on a temporary bridge therapy with anabolic agents like romosozumab before stopping denosumab? Patient is due for next dose of denosumab, but because of the dental treatment, you want to not give it. So, and with high risk of fracture, would you supplement with additional therapy or just?
In this patient, history of breast cancer, breast malignancy in general.
In general, sir, if the patient has a high risk of fracture once we stop denosumab and
I don't know. That also there is no evidence.
Okay.
No evidence.
Yeah.
It doesn't make any relevance. No, I don't think so.
Okay. Same thing. I don't know what was done. Only one thing is the Journal of Oral and Facial-Maxillary Surgeons says such patients should be given prolonged antibiotics if they undergo dental treatment. Oral hygiene gargles need to be maintained, and the surgeon has to ensure the temperature at which is grinding the bone. There shouldn't be high temperature and shorter time so that there are no deep sockets involved, which can then cause infection. So that is the only thing which is there. Yeah. Thank you. Thank you, sir. Thank you, ma'am.
I had a patient who had written for non-endurance and thought back that you did not ask for a dental checkup before it. My dentist just said that why did the doctor write for it? Sure. Right? To get a dental checkup before this thing, because she had some dental problem.
Thank you for that excellent last panel discussion. Before we jump into the last lecture and the closing lecture, We have a surprise talk on the non-pharmacological aspects of osteoporosis. For that, may I welcome Dr. Alka Chadda, please.
Hello. So everybody can hear me. Today, I'm here on request of Dr. Kaushik. He's given me some little time to speak before his talk, and I'm going to share some of the experiences that I've had working with senior citizens. And now it's a mix of seniors and juniors, and how the juniors, they make the seniors feel seen, and how the seniors make the juniors feel seen. So if you put a grandmother, somebody else's grandmother, with somebody else's grandchild, they both become very good friends because each one feels useless otherwise, but when they are together, they feel very much seen and useful to each other. So it was way back in 2014 when I lost my parents, one after the other, very quickly. I was invited to take care of some seniors. The first day, I was invited to take a yoga class for them because I'm a yoga teacher. And I was very low in my life at that time. So I said yes. Although it was about 35 to 45 minutes from my house, I had to go at 5:30 in the morning. But I said yes. And that was the changing and turning point in my life. So when I was, first day, there was one lady. Second day, she didn't come, when another lady came. Third day, one person came, a man came, and the lady did not come. But to summarizing what happened in the last 12 to 13 years is we started with one or two people, and today we have more than 200 members in our group. Now, when they joined, they were very quiet. They were not able to speak up, men and women. Men were from various parts of their life. They were very senior people who had retired. But what I saw was that they taught me a lot. They used to read Gita every day, and they taught me. They said, why don't you teach us about Gita? I don't know. I've never read Gita. My father presented the Gita to me some 7, 8 times, but I never understood the Gita that time. Then I said, okay, I'll read one shloka by one shloka and read the translation, and then we will see how we can apply this Gita in our life every day. This happened, and we became very close to each other. They started sharing their problems with me. Ultimately, my point is, like, one woman who lost her husband, let us say 17 years back, she comes and tells me the biggest pain in her life is that her husband never appreciated her cooking. So cooking is an art which she had in her, and she was doing that cooking every time. The whole world was praising her cooking, but not her husband. Appreciation is one part which makes somebody else happy. We are not here to talk about only the well-being of this senior citizens. When I was in Rome, I saw one session which was being talked about MAD. It is the role of music, art, and dance for osteoporosis. And you have the slide over here. I'm going to play some music. It's an experience which I'm going to give you. So I want you all to join me. It's just for 30 seconds, and then I'll stop the music. And then you have to share with me how are you feeling when the music is being played. Come, let's have the music. Next slide. Can you please stand up? It will help you to raise your endorphins. Yes, thank you. Come on, everybody. Come on, everyone. Show me some steps. Come on, show some steps. Show some moves, guys. Very nice. Thank you. Thank you, thank you. And just by moving our body, we can see the difference what it makes to our body. And dancing, when in this group, when we started, how did we come to dance was we were chatting every day. And one day we started singing old songs. I started with one song, I don't know which one it was, but let us say some song like Kisi ki muskurahaton pe ho udha. So that song, when we start, everybody starts joining that song. We have ladies and we have men. And they started singing songs. We started singing songs in a group. The group is a community and it gives you a sense of belonging. It gives you a sense of like you're being part of something. And that made all the difference. And working in this field for so many years, as we were singing, one girl started dancing. And then others started dancing, they all joined. And actually, what is happening is that one person, when makes the first step, no, the other person gets the bravery, they gets brave. But one person feels a little shy, then they don't want to come in front. So everybody was dancing. Then one day, one of our ladies said, why not we take a choreographer? So we called a choreographer, we paid money. This was way back in about 10 years back. And one dance was prepared on a song. And we were doing it in our colony only. But somebody saw there and they invited all of us to another very big platform. Now today, the situation is that every month, these seniors, they prepare one dance with a choreographer. And do you know how many platforms they go and perform? 4 platforms every month. Somebody or the other is always calling them, different groups are calling them. The result is that their mental health is improving because they have been a group, they're always talking to each other, sharing with each other. The memory is improving, the concentration is improving, and the PNIE axis, you know, everybody knows that the psycho and immunological axis has made their health much better. They have less infections. I have measured the bone density of only one person, and her name is Sukshi Dham. She's a Bengali lady. I was just talking to Dr. Kaushik last night that the Bengali ladies, they have very low incidence of depression. He didn't agree, but I know. My two sisters are married. My two sisters are married to Bengali people, and there is an artist. Let me tell you one thing. Do you agree that all of you have an artist in you? How many of you have an artist in you? Everybody has an artist. Raise your hand. Each one of us is having an artist in all of us. It's just that we have to ignite that artist. Dr. Kaushik, I know he has artists in his family. His wife is an artist. She's a dancer. His daughter, his son, and he himself, they are in theater together, and they do so much of things to advance the culture of India in UK. So a big round of applause to Dr. Kaushik. These are some of the slides. I don't need to stress, but one thing I want to say is that when we are stressed out in life, it's the biggest robber. The other robbers are cold drinks, alcohol, smoking, extra salt, but the stress is the biggest robber which takes away the calcium from the bones. This is a slide which my dad has always taught me that to be like water, and it is about, can you play the slide? It's a video. Anyway, when we are in music and when we are in art and when we are in dance, when we are mesmerized in some kind of art in our life, we are flowing like water. Water also teaches us resilience and flexibility and adaptability, and that's how we become. And I noticed that the ego becomes less. When you're concentrating on some music or some dance or some of your artistic hobby which you're having, your ego comes down because you're not worried about what is that. Concentrating in that particular art that you're doing. That is also called neuro art. That's nice. So this is what I wanted to share with you. I don't know I have what other slides you have. So this is the last slide, and it is about you are the artist. Your bones are the canvas, and you need not go to the clinic. If we can make a method in our clinics and help people to indulge in music, art and dance, or any kind of hobbies, we have programs in my clinic about cooking competitions, singing competitions, art competitions, and now I'm going to, as Dr. Kaushik suggested, I'm going to have a exhibition of all our people who are participating, and they can show their art, and that will be giving them a lot of appreciation. Last slide, please. Last slide. So if you want to run away, art is the way to run away, and you're still at home. Thank you so much.
Thank you, ma'am. So that really lightened the day. Next, for the next and the last lecture, but not the least, I would like to call upon Dr. Parthajit Das and Dr. Manoj Chedda sir to be the chairpersons. I don't think anyone needs an introduction anymore. And I would like to especially thank Dr. Kaushik Chaudhary, who has come here all the way, mentored, graced this event, and made this a success. So, big round of applause before the talk for Dr. Kaushik Chaudhary. And I invite him to talk about the basic nuts and bolts of osteoporosis care.
So this is a very busy slide. Can I have that slide? I can't remember otherwise. Dr. Kaushik Chaudhary from UK. It's an underplay. By now you realized he's a great person. I'm not talking of his rheumatological skills. Team player and coach. So because he was not in the field, but he saw to it that all of us were on our toes. And he's contributed in more than one way in making this session, this whole program up, and probably we'll wait for criticisms later on. But at least the fact that we have a very decent crowd at the end of the second day is heartening as an organizer. Dr. Chaudhary, please.
Thank you. Thank you, Manoj. And thank you, Pathajit. I think this is a bit of a downer after Alka's brilliant exposition, but I'll take a little bit of your time before we break for lunch. And it starts by thanking people. This has been in the pipeline for several months. Manoj and I started talking. My first contact with Manoj was in 2016 when this auditorium wasn't as grand as it is now, but he was then the ISBMR president, and he held a really great osteoporosis meeting. And I had the privilege of getting some of the stalwarts from UK to come here, and it was then. And we've kind of kept in touch, and then periodically we meet up in the IOF meetings. And I said, how about having a joint program between endocrinology and rheumatology? And there is a reason for that. I think osteoporosis care is going to be such an important issue for us. It cannot remain territorial. It cannot be the preserve of one specialty or another. And it was so refreshing to see enlightened orthopedic surgeons this morning. I think they are the exceptions that prove the rule. I mean, I bang my head against the wall when it comes to our 37 orthopedic surgeons in the place where I work, and none of them are interested in osteoporosis or setting up a fracture liaison service. And this is in a third world country like England. So there you go. But having said that, I think we need to come together. And in a way, this is the third iteration of a project that Puneet and I and Pathajit and I started almost 3 years ago. We used to have what is called osteoporosis dialogues. And for me, I have kind of lost interest in Takayasu's arthritis and Dada 2 and all those esoteric conditions that rheumatologists love to spend hours every weekend, 5 cities every weekend. And I think this is really far more important as a public health issue. We are an aging population, and unless we join hands and start thinking about this problem, we will not be able to cope. And I once made a comment which did not go down well with the head of the Department of Orthopedics where I work. I said, if I were a cynical man, and I'm not, I think you're not interested in preventing fractures because that somehow generates work for you. That's not strictly true. So I think what I'd like to do is give you a little bit. And I came into osteoporosis by accident. I was very much a IL-16 TNF person. About 10, 15 years ago, my senior colleague and former boss retired, and he used to run the osteoporosis clinic, and I kind of inherited it as the head of service. And what I realized is on the surface, it is very, very simple. And as you delve deeper and deeper into it, you understand how complex it is. you have one investigation practically. Well, Puneet will argue that there are now several, but we still rely on the BMD. You have 3 categories of drugs, and now, of course, we've got romosozumab. For a very long time, we had the bisphosphonates. Then denosumab came along and teriparatide. And now we have, of course, Rom. So there's not a huge plethora of drugs. And what I also learned is when not to start intervention. And I learned that not from my own self, and that is another message I'd like to share with you, but we have a network. We meet virtually every 2 months, a whole range of different people, gerontologists, endocrinologists, who are actually the real experts in bone health. But we serve a constituency of patients with osteoporosis, which is not the same as Manoj or Thomas does. Our patients are different, and we have to learn how to adapt the knowledge that is there to serve our patients. And I think that is lacking. We established the SIG, the Specialist Interest Group in Hyderabad in 2023. Parthojit is the chair of the SIG, and he's doing great work in furthering the practice of osteoporosis knowledge within the rheumatology fraternity. Okay, I'm conscious I'm taking up time. Having said that, so this isn't really what I won't stick to the script, but I'll try and see if I can maybe interest you, provoke you, and see if your glucose levels are dropping. I'm conscious, and your cortisol is also on its low. But the fact that Alchemed's dance has probably pumped some blood into our brain, so we'll be all right. Next one is, what do I do? So I am a rheumatologist, as you've heard. And I've got some, I've got sort of fingers in several pies, none of which I perform well, but, the enthusiasm it takes over from ability. And I would like you to pay attention to the last line. I really have no disclosures, but at this point, I'd like to thank our sponsors. It is because of them that we've been able to come together, and grateful thanks to all our sponsors. I really have no publications worth mentioning, and a very tenuous grasp on the subject I'm going to talk about. So keep that in mind, and then you won't be disappointed, okay? So, and one thing, we've heard a lot about the spine surgeons, and I do believe that this is something that caught my fancy. So if you want to succeed in life, you need a wishbone, or you need some degree of ambition. You do need a backbone, metaphorically and physically, and you need a sense of humor. So that is my philosophy, and we will move on. How do I do this? Just this. Oh, this one. Oh, okay, I'll manage. Thank you. One of the things that I would like to highlight is the fact that there is a wide spectrum of people looking after osteoporosis, and most importantly, osteoporotic fragility fractures. That is one of its strengths, but also its weakness. Unless we can coordinate our efforts, there won't be enough there to look after these patients. And one of the key elements, for example, that we probably lack in India, and certainly in large, big units in the UK, is the lack of a fracture liaison service. That is a very important point of contact for calibrating risk and ensuring right intervention. And although we have a lot of medications, there is too much emphasis on drugs, bone turnover markers, scans. A lot of osteoporosis is really the art of medicine. And some of it was, juxtaposed and elaborated this morning. You really need good clinical nows to make some of these decisions. We get too wound up on molecules, and ultimately, we lose sight of what matters. What matters in osteoporosis is the prevention, if you think of secondary prevention of further fragility fractures. That is the key value statement in osteoporosis. Whatever technology you have is designed to reach that goal. And not all of it is dependent on drugs. Drugs help, But we tend to ignore, because it is very difficult, other things like what Alka did, movement, weight-bearing exercises, diet, all of these things. When they come and see me for 15 minutes, I don't have time to go through it. Neither do their GP. So they're given pieces of paper and asked to go to websites. How many do? We don't know. We really don't know what the non-pharmacological component of osteoporosis care is. It has never been quantified, at least not where I work. And as I said, it's much of an art than a science. And I would strongly recommend is for us to gather together in local networks. There is always strength in sharing knowledge. So you might ask, why be interested in osteoporosis? And I'll tell you why. This is not a Western problem. It is very much a problem of our country. The aging population, the urbanization, the demographic of the patients that you treat, they are not exposed to the sun. They are not particularly good nutritious diet. Certainly living in high-rise flats, their exercise is not great. So there is going to be a tsunami of fragility fractures waiting for us in the next 10, 15, 20 years, and we need to be prepared. Access to DEXA isn't great either. We have one of the lowest, scanners per population, 1.5 billion people, right? So these are concentrated in urban centers. The standardization is poor. We discussed in Puneet's talk that the amount of training that is required, we quibble about grams per centimeter square and T-scores. I mean, it is irrelevant. First, get a DEXA. And then unless there is investment at a government level, district general hospitals should have DEXAs, I think. And then there is awareness, and you add to it the negative role of social media. Because, in the UK, and not just the UK, in the West, there was so much rejection of anti-osteoporosis therapies because people fanned the flames of this whole business of ONJ and AFF and all the rest of it, that people, elderly people who would have benefited and have had prevention of fractures shunned these drugs. And that is also a difficult area that I'll touch upon. The human cost of osteoporosis is great, and we seem to ignore it. When we meet for academic meetings, we kind of ignore the patient. Ultimately, all we are doing here is to make sure the patient does not have the next fracture. And as Balki said, fracture begets fracture. Forget the T-score, forget CTX, NTX, P1, NP. If someone's had a fragility fracture, they are likely to get another second fracture or a third fracture unless there is some intervention. And that intervention does not necessarily have to be a drug. So this is the cycle of problems with a vertebral fracture and with hip fracture. And there is a kind of thing is mortality is 25%. They don't die of the fracture itself. They die because they go into hospital. They have intravenous medication. They have anesthesia. Then they end up doing other things. They have catheterization, infections. All of those things contribute to mortality. And this is from the Royal Osteoporosis Society. And look at what patients feel. What they say after they've had a fragility fracture. It is not a ringing endorsement of our profession when patients are feeling like this. So I would like you to understand that osteoporosis has enormous costs in terms of billions of dollars, but it has also a very high human cost. So I will just very briefly, I won't touch on all of this. I think Puneet has dealt with osteosarcopenia. I'll give it a miss. We have touched upon treatment failure. And the important thing is what has happened in the last 15 or 20 years that those of us who have been in the bone field is we have transitioned from a very binary treat, not treat paradigm, which relied on a bone density scan to a much more sophisticated, nuanced way of trying to look at fracture risk. And that is where FRAX and other tools developed by Thomas and also the Garvan, and there's plenty of other tools, QRISK, they have become very useful, and I would strongly urge you to use them when you are in doubt about whether to start or not start treatment. Not everyone with radiological osteoporosis merits long-term treatment, because osteoporosis treatment is not like giving antibiotics for a chest infection. If you start on it, you've got to think it through. You've got to get the patient on site if you want compliance. If you don't have a compliance, no drug means no benefit. And then only can you start it. And then the choice depends on a lot of different factors, not least cost. In a healthcare managed system in the UK, we do not have unlimited access to abaloparatide or romosozumab. NICE restricts us. We can only use it in postmenopausal women, for example. There's nothing to say romosozumab doesn't work in men. But, so there are pros and cons of that. And we need to be careful about using the most cost-effective medication at a population level. Now, people here, you're probably treating well-off patients who can afford it. But if you think of the wider population, you'll probably still be sticking to oral bisphosphonates or IV zoledronic acid. And the other thing is, we keep on quoting guidelines, but more you delve and see patients, you realize a lot of these patients lie outside the guidelines. And you have to use your phone a friend or your own knowledge and experience to try and make some logical decisions. And sharing of experience. I keep on going back because I have learned so much from people like Eugene McCluskey, Neil Gittos, Zoe Paskins, the great and the good of the British osteoporosis, Qasim Javed. So when we have a difficult sort of rare bone disease, we send it to Oxford. There is the infrastructure there, I agree, but there is nothing stopping us from making these networks, okay. So I won't spend too much time from this. This is a justification of using one such fracture prediction tool and how it adds to our decision making. It is available in the Indian format, so from a drop-down menu. And remember, most fractures, fragility fractures happen cumulatively in terms of numbers in the patients who are osteopenic, not osteoporotic. So if you do not treat these patients, you're missing some. And if you're just treating osteoporotic patients on DEXA, you're maybe over-treating some people whose overall fracture risk is not that high. A young patient with a T-score of -2.7 is unlikely to fracture. We see this situation in lupus patients, even who are not on steroids. So keep that in mind. And then there is this new emerging concept of low risk, high risk, very high risk. This is if you want one document that is really very practically useful, please go to the NOG guidelines. They really are very practical, and you don't have to absorb it as in its face value. Use your judgment and absorb or apply what you think is useful. And now, of course, they have got Frax Plus, which deals with some of the drawbacks of the traditional Frax, but it comes at a price, which you can pass on to your patient, I guess. Unfortunately, we do not have access to Frax Plus at an institutional level. So always have a long-term strategy. Osteoporosis is not a 2020 game. It is a test match. And you have to be cognizant of patient preferences, their perception of risk versus benefit. So when you give someone IV zoledronic acid and their back pain, which is mechanical due to degenerative spine disease, doesn't improve, it means there's been a failure of communication before starting the drug. So expectations and risks, benefits are difficult conversations sometimes, and that requires a bit of experience. IV Zol is actually a default for hip fractures with front loading of vitamin D. And the reason is we would not like to use that, lose that contact we have when they're admitted under the orthopedic surgeons. You could argue in an ideal world, they can have bone density while they're an inpatient, and then we can titrate our drugs and give them anabolics. But that is not feasible where I work. And this combination, and I'm glad that our colleague, was it Ram? Yeah, who said, and I was so pleased to hear that these 3-month combinations of teriparatide and couple of denosumab is really not the way to go forward, and I'll leave it at that. If you are to use denosumab, there is nothing stopping you from giving it long term, and also have an exit strategy. There is no dictum that you should stop at 10 years. And the argument often is that, yes, there will be mounting risk, but you don't stop insulin at 10 years. You don't stop antihypertensives at 10 years. Why should you stop denosumab at a preconceived time frame? And the other thing with denosumab is there is incremental change as you go along, so you might as well. But when we do have to stop, we must have other backup. I'll leave that. Drug pauses are important with bisphosphonates alone, not with denosumab. Professor Thomas mentioned that. And it's about balancing risks and benefits, because these are both my patients, and you do get to see this. I have about half a dozen patients with ONJ and practically the same number with AFF, and they do happen. And there are no good ways of predicting it. The one thing I will say, if you are monitoring patients, and we don't, usually they get a phone call from our nurses, ask them about typing. That is a clinical way of anticipating something is not right. Make sure these patients have had scrupulous dental treatment and advice before going on to long-term ONJ, particularly IV-Zol. I think we've not probably touched on this, but you will often get a discordance between the hip and the spine. And for those of us who are programmed to look at fracts all the time, we will have to do some corrections. And the correction is to add 10% for every 1 T-score difference between the fract score is based on the femoral neck's bone density. So if you have a reasonably normal femoral neck but severe osteoporosis of the spine, you will tend to underestimate the risk of fracts on fracts alone. So you add 10%. So here, this is a constructed case. If you have a femoral neck minus 2.8 and a lumbar, the worst lumbar spine is minus 3.8, you add 10% to the final fract score. And that is all a useful way of getting around this problem of sampling. Least significant change, Puneet has mentioned, we tend not to repeat bone density scans too often. We only do it if we suspect there has been treatment failure, or in patients where we have not intervened with a drug. Once they're on a drug, this sort of pressure we have from patients, why aren't you looking at my scan to see it has improved? You have to resist, because doing it too often will not give you any meaningful data. And again, there's a cost involved. Obviously, in the private sector, the dynamics are different, but we have to use our resources very carefully. The one thing to remember, and which is why we're having all this conversation, is recency of fracture will determine the next fracture. So you're at your worst risk soon after the index fracture. So the quicker we can intervene, the better. All drugs help, some more than others. To quote George Orwell, all animals are equal, some are more equal than others. So we have romosozumab, which is the newest kid and the most popular kid in town in terms of its efficacy. But that doesn't mean other drugs don't work, and we have to be mindful of the cost involved with some of these drugs and when we apply them. We've just begun to dip our toes with abaloparatide. We probably have about 10 or 12 patients now. We'll have to wait and see. The understanding is they work better on the hip than teriparatide. And of course, our population of older patients have a lot of cardiovascular comorbidity, so we have to be a little bit careful in using romosozumab. We missed that. So we've talked in the last session about sequential therapy and combination therapy. Most sequences work, and there is sometimes some sequences are better than others. I will skip osteosarcopenia, but to emphasize that this is an increasingly important area for us, and it cannot be seen in isolation to osteoporosis. The interaction between these two concepts is very important. So when it comes to individual complex patients, I'll reiterate what I said earlier. It's expert opinion matters. So when we have people like Manoj and Thomas and colleagues, they can, that this is the old phone a friend concept in Who Wants to Be a Millionaire. There are relative therapeutic modalities, and it is important that we use it well and rationally, and don't get too swayed by measuring stuff. And finally, there is much work to do in terms of systems change. First of all, we must think of creating networks of experts. We must lobby the government at the state level or at the national level for a change in how osteoporosis is perceived. And then there's a huge amount of work, and the youngsters in the audience, take to social media and propagate the importance of osteoporosis and bone health. And of course, training of healthcare personnel, radiographers, all of that is important. Last but not the least, a fracture liaison service is probably one intervention that has been proven to be incredibly helpful. So I would like you to think seriously about osteoporosis, ladies and gentlemen. And this is one of my favorite quotes, which I cannot resist from showing, is William Osler, who worked about 60 miles from where I work, down in Oxford, where Qasim Javed works now. He was the Regius Professor of Medicine at Oxford, a Canadian. He's the guy who started the medical rounds because he used to be at the Johns Hopkins, which had a circular kind of building. So that's where the medical round came in. But he then moved to Britain, and what he said is there for you to see. And thank you very much.
Thank you, Kaushik, for the wonderful talk and covering osteoporosis theme synopsis in such a lucid way. So I have no questions. Any questions from the audience? This is probably the best time you can ask or clear your doubts.
We don't. There are the little higher. So there are some. The case is slightly more reputable. If you buy the song, then we have time. So
So if there's no other question, we'll close the session. I'll probably ask Dr. Manoj Chadha to give the vote of thanks.
Yes, please. I would invite Dr. Manoj Chadha to please come here and give.
I'll say to you what. I think, thank you, Chadha sir, the organizers, all the delegates, speakers for doing a wonderful job. I think there are a lot of learning points. We had interesting cases, panel discussions. It's quite a good meeting. Hope we have learned from the meeting, and we want to translate our knowledge into action when we go back to our patients, and we'll try to help our patients in a better way. I think this all I want to say really. We'll hope to see this kind of meetings very regularly, probably sometime next year. And we wish all the best. Thank you.
Actually, I had planned, to give my thank you lecture with a single slide, but unfortunately, I don't have that slide, so we'll keep it for next year. But from the bottom of my heart, thank you to all of you that you've been still sitting here past 2 o'clock when you could be getting ready for the football match, or there's a cricket match also that's going to come up. I've got a list of points so that I don't forget something, but if I leave out someone, please excuse me. Let me start by thanking my colleagues first from the Department of Endocrinology. Nishit and Renu, they've always been as a support. You were talking of backbone. These are the guys who've been with us when it comes to osteoporosis. As a matter of doubt, I don't know how many of you know that Nishit and I have worked together, and we've been longer together than we've been with our wives. 1983, so that makes it 44 years. We were co-registrars in KEM Hospital. But the next generation, Asim, Niragi, Amrita, my colleagues from the type 1 diabetes clinic, they've done the the giant part of the work. We've just been ordering, but they've done the maximum work. And you've seen that in the last 48 hours, but we've seen it for the last 4 months. I'm really grateful. And it's not just for the sake of saying it. Thank you, Niragi. Thank you, Asim. Amrita has left for a little personal work, but great efforts. I need to thank on record the marketing department of Hinduja Hospital who helped us out. The catering department of Hinduja Hospital, who I feel have done a very good job, and there's something nice waiting for you after this. As Kaushik said, this would have not been possible without the help of our sponsors. And it's not a long list, but they've done a great job for us. And I'd like to thank the friends from Dr. Reddy's Laboratories, Sun Pharma Limited, Intas Limited, Torrent, and USV. Thank you very much, because without your support, this wouldn't have been possible. The faculty members from Mumbai and from out of Mumbai, great help. Thank you, guys. I can see Thomas, Sanjay was around, Shinjan left in the morning, Hemant, Pramod, thanks a lot. And nothing is really possible if we don't have audience. So it's great that you've been there. I think some of us have left for whatever reasons. And I hope 2027 will come up in next year. Thank you very much once again. I request you to join us for lunch.
Dr. Fulrenu Chauhan, please. Yes, it's okay. Okay.
But just put my presentation. Just put my
Thank you. नहीं मैं आपका ऑन कर रही हूँ 6 won't do. Okay. 1 minute.
Get back to the. Thank you.
ये आपका स्लाइड ऑन कर लो नहीं रुक पहले यहाँ से लेती हूँ वन यू जस्ट टेक फ्रॉम हियर एक ऐसा पूरा ले सकते एक ऐसा ले ले खाली इधर का लाइक दिस जस्ट यू जस्ट टेक अच्छा शी इज देयर ओके yeah